Session which has been supported by AstraZeneca, and I invite Dr. Chirag Desai, who is a Senior Consultant Medical Oncologist, HOC Vedanta, to elaborate on HER2-low as an emerging entity. Over to you, sir. Can we have the mic on the podium on? Sir, can you press the button over there? Ek button over.
It's on.
It's on.
Yeah. So good morning, everyone.
Yeah.
And thanks to the organizer for giving me the opportunity of speaking about HER2-low metastatic breast cancer, which is emerging as the new entity in the arena of breast cancer. And I'm delighted to see that there are many more surgeons than the medical oncologists in this audience today to listen about HER2-low metastatic breast cancer. So this is AstraZeneca sponsorship session, and some of the slides are provided by AstraZeneca. That's the disclaimer. Can I have my presentation?
Can we have Dr. Chirag's presentation, please?
Great. So this is the outline of my presentation. I will begin with the introduction and paradigm shift in HER2 testing. So traditionally, all these years, what we have been seeing is that we divide HER2 as a binary, HER2 negative and HER2 positive. And what do we mean by HER2 positive is IHC 2 plus with FISH positive or IHC 3 plus, and rest of everything IHC 0, IHC 1 plus and IHC 2 plus with FISH negative is HER2 negative. And there has been some shift which has been occurring for a long time, but we have realized the importance of this shift very recently, and now we want to categorize as IHC 1 plus and IHC 2 plus FISH negative as HER2-low. IHC 0 is still HER2 negative. There is some shift there also, which I will allude to in the last slide. And then IHC 2 plus FISH positive and IHC 3 plus are HER2 positive. Evidence to date is insufficient to categorize HER2-low as a different entity, but the evidence is emerging, and that's what I will be discussing now. So half of all the patients with breast cancer are showing low levels of HER2 expression. And if we look at this entity with HER2-low positivity, they are having larger tumor, and they are having more nodes as compared to the HER2-0 level. And it shows that there is possibility of some biological difference in this particular category. If we divide between hormone receptor positive and negative, we can see that almost 2/3 of hormone receptor positive, which are categorized as HER2 negative earlier, are actually HER2-low, and 1/3 of what we used to call triple negative are actually HER2-low. So history of clinical trials in HER2-low, and mind well that most of the trials were negative as shown in this slide. The top one is trastuzumab with chemotherapy, except for one trial which is NSPP-B31, we showed some improvement in the outcome in HER2-low patients when they were given adjuvant trastuzumab. Except for that particular trial, all the trials for trastuzumab, TDM1 and pertuzumab are negative. Now, there are two ways of treating these patients. First is with naked antibodies, just only antibody, nothing else. And chemotherapy is given with that antibody. And that antibody triggers antibody-dependent cellular cytotoxicity as well as cell-mediated immunity, and that's how they are effective. But when antibody-drug conjugate is being used, a drug is being carried through the antibody to the tumor site itself, and the drug is deployed at the tumor site. And I will show that in the coming slides. So reason behind the efficacy of ADC, and mind well, TDM1 also is an ADC, but it didn't work in HER2-low metastatic breast cancer. And I will show you in the next slide why it didn't work. But how the ADCs work. So antigen binding site of the antibody is carrying the drug, which is here, to the tumor site, and the drug is deployed after internalization, and within the cell the drug is being deployed, and with some of the antibodies, some of the ADCs, the drug is diffusing to the neighboring cells, and that is called Innocent bystander effect. So if you look at TDM1, trastuzumab deoxycarbazine in the middle row and TDXD in the last row. So all these three ADCs are targeting trastuzumab, or rather HER2 molecule. TDM1, the linker is non-cleavable, so very few molecules are actually diffusing into the cells. And the drug antibody ratio is 3.5:1, while if you look at the last row, TDXD, it is 8:1. The cytotoxic moiety is the anti-microtubule drug in TDM1, while it is the topoisomerase 1 inhibitor, which is more powerful as the anti-tumor agent. And Innocent bystander effect also is there with the two molecules on the right side, not with the TDM1. So ADCs in HER2 low metastatic breast cancer. So what data do we have? So we have three antibodies that we will be discussing. Trastuzumab deruxtecan a little in detail, a couple of slides about sacituzumab govitecan, and then just one slide about trastuzumab deoxycarbazine. So Destiny Breast 04 is the open label multicenter phase 3 study where HER2 low patients are being treated after 1 to 2 prior lines of chemotherapy. Remember, 1 to 2 prior lines of chemotherapy. And the primary endpoint in this trial is the progression-free survival in hormone receptor positive patients. That is the primary endpoint. The secondary endpoint is overall survival, PFS in all patients, and so on and so forth. But it is not primarily looking at triple negative patients. So that's something that we need to understand. That will be useful in the further discussion. The PFS in hormone receptor positive patient is 10.1 months. Remember this figure. And in all patients, it is 9.9 months, and it's significant with excellent hazard ratio, excellent p-value. If you look at the overall survival, so overall survival also is excellent, 24 months versus 17 months in hormone receptor positive, and 24 months versus 17 months in all patients. And if you look at all the various subsets, in all comers, the drug is more effective so far as the primary endpoint of PFS is concerned. And this is the exploratory endpoint in triple negative patients, that is hormone receptor negative and HER2 low patients. Remember this figure, with TDXD, the PFS is 8.5 months and the survival is 18.2 months in this 58 patients, small number of patients, right? So this is the waterfall plot of the change in the size of the tumor. Whatever is below the line of 0, it is the reduction in the tumor size. It's very evident that with TDXD, the reduction in the tumor size is much better as compared to the treatment of physician's choice. So, if you look at the toxicity, we understand, looking at the literature, that TDXD is a toxic drug. But if we look at that this was a 2:1 randomization, so twice as many patients as chemotherapy were given TDXD, and the PFS was double. So exposure to TDXD is 4 times. And it is being written as the exposure adjusted incident rate, and total patient years of exposure is 4 times, 63.5 versus 283. And if you look at that, all the adverse event or severe adverse event and so on and so forth is actually better with TDXD as compared to chemotherapy of physician's choice. And if you look at the adverse event of interest, so trastuzumab deruxtecan has 2 main side effects. One is the interstitial lung disease and another is cardiotoxicity. Now, if we look back and if you look at the Destiny Breast 01 trial, there were 5 deaths and the incidence was much higher. In Destiny Breast 03 trial, the investigators were experienced and the patients were not exposed to many drugs earlier. And because of that, there was no death in that trial because of interstitial lung disease. While here, any grade of ILD is 12.1%. Look at the last column, the top one. But there were 3 deaths in this trial. So these patients were exposed to multiple chemotherapy earlier, and because of that, the death was slightly higher, but 0.8%. So not a small number, 3 days, but still it means that we have to be careful when we use this drug. And if the patient has any pulmonary symptom, we cannot take these symptoms as lightly, and we have to treat them. So once the drug is available to us, we will train ourselves in using this drug. And if you look at alteration in the ejection fraction, as well as cardiac failure, some of grade 1, grade 2 toxicity, but no grade 4 or grade 5 toxicity, and no cardiac failure practically, no grade 3, 4, 5 cardiac failure. And because of this data, FDA has approved this targeted therapy for HER2-low metastatic breast cancer, accepted in the NCCN guidelines as well. Now, if you look at the other molecule, which is sacituzumab govitecan, which is not targeting HER2 per se, but we are talking about HER2-low, which were traditionally considered to be HER2-negative patients. So there are two trials of sacituzumab. One is this one, ASCENT study, which was done with triple negative patients. Some of them were HER2-low. And in this trial, in ASCENT trial, at least 2 chemotherapy were given to the patient before giving sacituzumab. And if you look at the progression-free survival, in HER2-0 on your left side and HER2-low on your right side, if you look at the PFS on your right side, it is 6.2 months. And if we compare with that in a small number of patients, in TDXD trial, it was 8.5 months. So this is the primary endpoint for this trial, not for the TDXD trial. If you look at the survival, look at your right side, which is for HER2-low patients, it is 14 months, while it was 18 months with TDXD. So we cannot directly compare the two trials, and in the TDXD trial, triple negative was not the primary or secondary endpoint. So this was the secondary endpoint, not to be given so much of importance, and I will come to this point a little later in this presentation. So the conclusion was that sacituzumab works in triple negative as well as HER2-low patients. Then there is another trial with hormone receptor positive and HER2 traditionally negative patients, and this trial the patients were heavily exposed to the chemotherapy, 2 to 4 previous lines of chemotherapy and hormonal therapy. And in these patients, they were well balanced for the baseline characteristic. The PFS was 5.5 months, while it was 10.1 months with TDXD, which was the primary endpoint in that trial. So twice the PFS, and overall survival was 13.9 months with sacituzumab govitecan versus 24 months with TDXD. So more preserved patients with TDXD, but the number is itself so very evident that TDXD seems to be working much better as compared to sacituzumab. And sacituzumab also is toxic, not devoid of side effects. And those of us who have little experience with this drug, we know that it is difficult to handle at the recommended dose of 10 milligram per kilogram, day 1 and day 8 every 3 weeks. So FDA has approved sacituzumab for triple negative as well as for hormone receptor positive HER2 negative patients. Trastuzumab deocarmazine. I remember the song of the movie प्यार झुकता नहीं है, मिथुन चक्रवर्ती पद्मिनी कोल्हापुरी, कि तुझे अपना साथी बनाने से पहले मेरी जान मुझको बहुत सोचना है. I mean, this is just phase 1 data. Let us look at phase 2, phase 3 data of this drug. Sorry? We will discuss outside. So now we have realized that HER2-low is emerging as a special category. So are we ready to accept HER2-low? Are our pathologists ready? Are our surgeons? Of course, there are many of them over here, and our radiologists to do the biopsy for us. So the challenges that we face right now is there is no clear definition of HER2-low. The definition is emerging. I just said the definition. Lack of awareness of HER2-low, and I am sure that at least this audience will be aware of HER2-low now. Tumor quality, heterogeneity, subjective IST analysis, limited tissue quantity, and IST limitation. I think that we need to keep discussing with our colleagues about these factors so that we pick up. The basic confusion occurs between IST0 and IST1+. That's where some of the pathologists are not very clear about how to categorize them. So far they didn't care. But now we want them to clearly tell us whether it is IST0 or IST1+. And in last year's ESMO article, ESMO expert consensus statement on the definition, diagnosis and management of HER2-low breast cancer. Look at the right column and the top one. HER2-0 is further subdivided into HER2-null, no staining at all, and HER2 ultra-low, that is a little staining, but less than qualifying for HER2 1+. Now, whether this definition is required or not, there is a trial called Destiny Breast 06. And if this trial, this is the outline of this trial, it is ongoing right now. Some of centers are there in our country as well. So that will tell us whether we need to further categorize from HER2 low to HER2 ultra low or not. This is the ESMO guideline. I hardly can read anything. This is looking confusing. But there is another excellent article published in June 2023 in the Breast Journal, How I Treat HER2 Low Advanced Breast Cancer. So if it is the hormone receptor positive, give hormone first. If patient is the BRCA positive, give olaparib. If not, give at least one chemotherapy, followed by TDXD, followed by sacituzumab. If the patient is HER2 0, give sacituzumab followed by whatever chemotherapy you want to give. If the patient is triple negative, hormone receptor negative, give chemoimmunotherapy if PDL1 positive, followed by olaparib if BRCA positive, followed by chemotherapy, and then for HER2 low, it is either TDXD or sacituzumab, and my preference will be slightly for sacituzumab because it has phase 3 trial data. With TDXD, it is the subset analysis, exploratory analysis of a phase 3 trial. But both the drugs can be useful. So to conclude, HER2 low has already come up as an established entity which we need to look at, and what we used to call triple negative or HER2 negative, many of them are actually HER2 low, and they are the candidates for TDXD at some point in time when they become metastatic. So thank you very much. So I have saved 13 minutes, so maybe we can take a couple of questions. पैर झुकता नहीं, बार बात करेंगे. Thank you very much.
Thank you, Dr. Chirag Desai. We begin with our first session, which is about defining the surgical margins in breast cancer. And as chairpersons, I would like to invite Dr. Debanshu Bhaduri, who is a senior consultant in surgical oncology at M.N. Budrani Cancer Institute, and Dr. Vani Parmar, who is a professor in the breast surgical oncologist at TMH, Mumbai. Before I hand over the session, my sincere request to speakers and chairpersons to please stick to the time allotted to you. I will be ringing the bell when your 5 minutes are over so that we do not exceed the time. So it's my pleasure to invite the first speaker, Dr. Neha Chaudhary. May I request the chairpersons to please be seated over there, ma'am? You want to sit here? Okay, that's fine. Our first speaker is Dr. Neha Chaudhary, who is a consultant surgical oncologist at Narayana Super Speciality Hospital, Howrah. Over to you, Dr. Neha.
Thank you, organizers. I will start by saying that I might take a couple of minutes extra because I got 30 slides to present. So I'm presenting about surgical management of triple negative and HER2 positive breast cancer, stage 1, what is the treatment strategies, and optimal auxiliary management. It was presented by Anita Mamtani at SABCS. So the ever-going debate between surgeons and medical oncologists to give chemo or upfront surgery, that's what we are going to discuss. So the dilemma here is most of the trials which tell us to give neoadjuvant chemotherapy in early stage breast cancer are based on data on stage 1 and stage 2 disease, and the stage 1 representation is very small here.
Doc, you have 30 slides, right?
Yes.
Yeah, so you got to watch the clock.
Oh, absolutely. Don't worry. So, in spite of that, the use of NSAT is increasing as the day is passing. So, what is the debate? Debate is the question is, are we increasing chemo-related toxicity by giving NSAT first in stage 1 disease? Are we missing out on de-escalation options? Is the surgical downstaging needed here because 2 centimeter, it won't make a difference in primary and treatment of occult disease, whether it will make a difference or not? That is the question. So I'll be overviewing in 4 sections. First is the data supporting NSCT in early stage TNBC and HER2. What are the de-escalation opportunities? What is the nodal burden in this subset? And what is the need for ALND here? If we look at all the trials, TNBC and HER2, then we see that the representation of stage 1 is extremely low. In trials of HER2, we see it's just 0%. And in CreateX, Keynote 52, Catherine, everywhere the representation is less than 5%. If we look even at CreateX subset, then again in the patients who did not achieve PCR and got capecitabine, in the stage 1 subset, there is no additional benefit of adding capecitabine. If we look at the NCDB analysis, again 5-year OS in the NSCT versus adjuvant group is not different. Again, we all know about the Sarah Tolani trial and we agree, less than 3 centimeter, HER2 positive, node negative, we would like to avoid anthracycline, give only paclitaxel with excellent outcomes. Affinity trial, again, pertuzumab can be avoided in stage 1. So if we look at the nodal burden again in this subgroup, across the trials it is around 9 to 16%. And mind it here that here the axillary ultrasound was not done and all, so actual nodal burden would be actually lesser. So even if it is node positive, we can safely omit ALND because we all know about ACOSAC Z11, excellent 10-year DFS and OS with less than 2% recurrence in axilla, and the surgical morbidity is significantly lesser. What is the rate of ALND in this subgroup? Again, 15 to 16%, but here they have taken both T1 and T2 together. In T1, it would be probably lesser. So what the question here is, which approach minimizes ALND? And that is what the MSKCC group did. They looked at their data between January 20 and December 2022. They took all the CT1N0 patients, and they saw that their 9% of the patients received neoadjuvant chemotherapy, 68% got BCS upfront, and 23% got upfront mastectomy. Their indication for ALND was this any patient post-NSCT if it is SLN positive, for more than 3 SLN at upfront surgery, and if the patient was getting mastectomy and not a candidate for PMRT, then even for 1 or 2 nodes, they did a clearance. The patient demographics were balanced, and what did they look? They saw that the rate of ALND was actually higher in the neoadjuvant group. It was 6%, compared to only 1.7% in the upfront BCS and upfront mastectomy group. They also saw that there was a significant de-escalation in the upfront surgery group. If we look here, then 36% of TNBC is getting lesser chemo, 10% is not getting any chemo. Again, 66% of HER2 is getting lesser chemo, 13% is not getting any chemo. So they concluded that less than 2% of these patients actually need ALND. There's no advantage of adding NSCT to decrease axillary clearance. There is a potential de-escalation of systemic therapy.
Doc, we need to conclude now.
And this is my last slide. So they also concluded that the evidence for NSCT in stage 1 is actually lacking. Heavy nodal burden in this group is less, and ALND is infrequent. Axillary downstaging should not be the criteria to add on NSCT. De-escalation therapy should be looked into, and we need new continued refinement treatment for this subset. Thank you.
Thank you, Dr. Neha Chaudhary. I now call upon Dr. Namita Pandey, who is a breast oncoplastic surgeon at Dr. L.H. Hiranandani Hospital.
Good morning to one and all. I'll compensate for Dr. Neha because she had 30 slides to present. I have just 3. Thank you, organizers, for giving me this opportunity to be on board and speak on the topic, which is management of ipsilateral breast tumor recurrence following breast conservation surgery for ductal carcinoma in situ, a data-free zone. This was presented by Dr. Brian Deskin. The background of this study was to establish the feasibility of reconservation of the breast in an already treated case of DCIS who faced ipsilateral breast tumor recurrence. Though we have a growing body of data to establish the feasibility of reconservation in an invasive breast carcinoma, but there has been no data or recommendation or any randomized trial to confirm the same in case of ipsilateral breast tumor recurrence in case of treated DCIS patients who have undergone breast conservation. The aim of this study was to compare the outcome of mastectomy versus reconservation therapy for a large group of patients of DCIS who have faced ipsilateral breast tumor recurrence. They selected the women who were treated with BCS for DCIS at MSKCC who developed ipsilateral breast tumor recurrence as a first event, and between those treated with mastectomy versus reconservation, they compared the clinicopathological characteristics for the initial and recurrent tumors, the use of primary and secondary RT, that is post-ipsilateral breast tumor recurrence, and or tamoxifen, the rate of third event, breast cancer specific survival, and the overall survival. In the results we see that there is increasing frequency of breast conservation surgery, that is from 1983 to 2013, they were nearly 47%, whereas in case of 2014 to 2023, nearly 56%. Sorry, 56%. The clinical characteristics of the initial DCIS, in case of mastectomy, we see more amount of necrosis versus a lesser amount of necrosis in case of reconservation. The comedohistology was also more in case of mastectomy versus reconservation. Those who underwent mastectomy, most of them had an initial RT, that is 61% versus 21% to those who underwent reconservation. If we come to the tumor histology, we see there was no difference in the invasive versus DCIS component in the mastectomy versus reconservation component. The DFI, the disease-free interval, was almost comparable in both the case. If we see the number of patients who received both the primary as well as the secondary RT, it was nearly 5.9 in case of reconservation, whereas those who received both the primary and the secondary RT in case of mastectomy was just 4.5. And neither, those patients who received mastectomy had 37% who received neither and 41% in case of reconservation. If we see the third incidence of local recurrence was seen least in case of those patients who had received both the primary as well as the secondary radiation. Though the recurrence of the third event, that is the re-recurrence, was more commonly seen in those patients who underwent reconservation, but the overall survival and the breast cancer specific survival was almost comparable. So they concluded that the treatment with mastectomy was associated with less favorable initial pathology and more frequent use of primary RT. Re-recurrence was more frequent with the reconservation of the breast, and breast cancer specific survival and overall survival were almost comparable. So the data suggests a wider role of the reconservation and further study of the relationship between secondary RT and the rate of third breast events. Thank you so much.
Thank you, Dr. Namita Pandey. I would like to now call upon Dr. Urvashi Jain, who is a consultant oncoplastic and reconstructive breast surgeon at Frimley Health NHS Foundation Trust, UK.
Good morning, everyone. Thank you, Jay, Dr. Manyar, and the MOC organizers for this very kind invitation. It's always lovely to be back home in Bombay. So, before I begin my presentation, I want to say that I have no conflicts of interest to declare, except that I share a great camaraderie with some of the authors on this paper, but I promise I remain to be unbiased. I want to start by saying and making this disclosure, and I will quote Dr. Cody. I'm in general much more influenced by tumor burden, a composite of specimen size, tumor size, and extent of tumor in each margin rather than the margin width alone. And I abide by this. I'll tell you in a minute why. There has been a lot of debate, and this has been a contentious issue for decades now, even at the last ABS meeting that was held in Belfast in May. It also got me to work and present some data on margins at the last St. Gallen conference. And after having worked through all of this during my time at Cambridge, I have some very spiritual things to say about this. So this is a streetlight effect where we tend to look at where the light is the brightest rather than where the key is lost. And I feel that it is a similar situation with margin width as well. Before I delve into the data, I want to speak about why margins are important in DCIS and how they are different from invasive disease. This is a very beautiful picture that depicts how a discontinuous pattern, growth pattern of DCIS is seen within the ducts, and how 40% of the times we're likely to see skip lesions. Now let's get into the nitty-gritties of the data and the stats. I will try not to bore you with too much detail. Most of you can read from the slide, and I'm sure have the presentation and abstract with you. So this was a study done in the UK, and there were about 17,000 women with newly diagnosed DCIS between 2003 and 2014 from the NHS breast screening program. The idea was to assess the association between surgical margin width and the time to recurrence using retrospective histological margin data from routinely collected data sets. With a median follow-up of 8.2 years, the primary endpoint was time to recurrence, and the secondary endpoint was overall survival. These are the baseline characteristics of this patient population. I want to highlight a few things here. If you look at the number of wide local excisions that were 2 and 3 and the grade of DCIS, and I'll tell you why that's important. So it met the primary endpoint of the 3 thresholds that were kept for margins, and all 3 curves show that a margin of more than 2 millimeter did shorten the time of recurrence in these patients. This model also showed that the risk of recurrence increased as the number of wide local excisions increased, but you can see a wide confidence interval here, and I will go back to this slide again. This is perhaps because the number of patients in this group were really short. The overall survival was also significantly better, with about 25% in patients with more than 2 millimeters when compared to less than 2 millimeters, and about 28% in patients more than 2 millimeter again as compared to 1 to 2 millimeters. So they concluded saying that DCIS with histological margins of less than 2 millimeter, when adjusted for clinical factors, have significantly worse time to recurrence and overall survival rates as compared to margins more than 2 millimeter. There is an increased risk of recurrence with increasing number of wide local operations. However, there's more data that needs to be generated when looking at this. And 78% of recurrences were invasive breast cancer, which is in keeping with global data. I'd like to focus on some of the shortfalls of all the studies and data that we have with DCIS, and that they're all observational and retrospective, and most of them are fraught with biases, as you can see here. I'm aware of the constraints with time, so I'm going to skip through these slides very quickly. Happy to take them during the panel discussion. I just want to allude to some of the factors that really affect margin width or recurrence per se, rather than margin width by itself. And I want to particularly highlight the landscape of DCIS and how it's changing. High-grade DCIS is now a separate entity as compared to low-grade, and there have been a number of trials that are ongoing currently. This is my take-home in a nutshell. I'd like to thank these two very dear and wonderful and absolutely brilliant women who've given me these insights and perspectives on the subject. And I'd like to invite you all to the upcoming India Breast meeting to be held in April. Thank you.
Thank you, Dr. Urvashi Jain. I now call upon Dr. Purvi Thakkar, who is a breast oncoplastic surgeon, to give her presentation.
A very good morning to everyone. A quick thank you to the organizers for the opportunity. Showing? Yeah, thanks. So that's me, and that is my topic for today: surgical treatment of women with breast cancer and a BRCA1 pathogenic variant, an international analysis of the impact of bilateral mastectomy on survival, presented by Kelly Metcalf from the University of Toronto at SABCS 2023. So we all know that BRCA1 and 2 mutations are seen in almost 3 to 4% of patients with breast cancer. The impact is the increased incidence of ipsilateral and contralateral breast cancers along with ovarian cancer. There are various surgical options available, from conservation to unilateral to bilateral mastectomy, and that is the point of discussion of this study. So the objective was to evaluate the risk of contralateral breast cancer and breast cancer specific mortality by surgical treatment in women with BRCA1, specifically pathogenic variant, and non-metastatic breast cancer. So eligible subjects were identified from an international cohort. Clinical data obtained through medical charts, demographic data through patient questionnaires, essentially retrospective, and follow-up was from the date of diagnosis to the date of last follow-up or the date of death. Inclusions were all BRCA positive, BRCA1 positive patients, stage 1 to stage 3. The extremes were excluded, that is DCIS or stage 4 breast cancer. Bilateral breast cancers were also excluded. Of course, patients with no follow-up were excluded as well. So they found 2,482 eligible participants recruited from 11 countries across 26 centers over a period of 26 years almost, from 1995 to 2021. The mean follow-up was 8.9 years. The mean age at diagnosis was 43, most of them less than 40 years of age, that is 42%, around 33% from 40 to 50 years of age, and the remaining 24% over 50 years of age. The most frequent surgery performed was unilateral mastectomy at 46%, 34% underwent breast conservation, and the remaining 20% underwent bilateral mastectomy. Now, these were the observations. Regarding patient characteristics, I have just tried to simplify my conclusion with each observation. So the patients in the bilateral mastectomy group tended to be younger, diagnosed more recently, and had the shortest follow-up than the other groups. You can see that in the numbers here. Almost 50% were less than 40 years in the bilateral mastectomy group, and the follow-up was 6 years compared to over 9 years for the other two groups. Regarding clinical characteristics, both the BCT and bilateral mastectomy groups had smaller tumors, that is T1 tumors, whereas the unilateral mastectomy group had more of bigger tumors, T2 tumors. Most of them were node negative across all groups, most of them grade 3, around 75% ER negative, as expected in the BRCA1 variants. So that means that unilateral mastectomy group in this cohort had larger tumors and more likely to have node positive disease compared to the other groups. Regarding treatment, both BCT and unilateral mastectomy groups had more patients receiving chemoradiotherapy, whereas patients who underwent bilateral mastectomy were more likely to undergo oophorectomy and less likely to receive adjuvant therapy, including hormonal therapy. Regarding contralateral breast cancer, the incidence that they found in this cohort was around 11.5%, which was least in the patients who've undergone bilateral mastectomy. Obviously, logically, that is 0.8% versus 10 and 11% in the other two groups. The separation is clear in the graphs. The black line at the bottom is the bilateral mastectomy group. When the breast cancer mortality was seen in the contralateral breast cancer groups, the conclusion was that patients who developed contralateral breast cancer had a higher risk of death irrespective of age. As you can see here on univariate and multivariate analysis across age groups and across the age groups, that's it, on univariate, multivariate analysis. When they saw breast cancer mortality, the incidence was 11.5%. The mortality was highest in patients who underwent unilateral mastectomy. Again, the separation of curves, the line on top is the unilateral mastectomy group. Breast cancer specific survival was least in the unilateral mastectomy group compared to the other groups. When breast cancer mortality was stratified by surgery type across age groups less than or over 40 years, on multivariate analysis, there were no significant differences in the risk of death between patients who underwent BCT or unilateral mastectomy versus those who underwent bilateral mastectomy. So although the incidence of contralateral mastectomy was lower in the patients with bilateral mastectomy, this did not translate into a significant survival benefit, or there was no worsening of mortality in the other groups. So the conclusions were that women with BRCA1 positive and bilateral mastectomy were significantly less likely to develop contralateral breast cancer, which is significant. Women with BRCA1 positive and contralateral breast cancer were twice as likely to die of breast cancer, again significant. However, bilateral mastectomy was not significantly associated with reduction in mortality compared to breast conservation. But this was very heterogeneous data across geographical areas with a lot of variation, prolonged recruitment over 26 years, regional and chronological variation of treatment protocols over a period of over 25 years, and the follow-up was also variable, especially across the groups. So my take-home from this would be that bilateral mastectomy definitely reduces the incidence of contralateral breast cancer. However, since this does not translate into a significant survival benefit, breast conservation may be offered as an option to patients. But the caveat is that this should always be an informed decision after discussion with the patient. Of course, future considerations, randomized studies,
You need to
compared
finish
studies
now, please.
required. Yeah, I'm done. Thank you.
Thank you, Dr. Purvi Thakkar. Our last speaker for this session is Dr. Karishma Kirti. Dr. Karishma is a consultant breast oncoplastic surgeon at Jaslok Hospital and Research Center.
So I just want to add here, we will have a summed up thing from all the 5 abstracts together at the end from us.
Didn't get you.
So we will do a sum up at the end for all the 5 speakers.
Okay.
Instead of breaking the flow right now.
Yes, yes, yes.
Good morning, everyone. I thank the organizers for giving me this opportunity. The abstract I'm presenting today is the relationship between margin status of less than 2 millimeters and local recurrence in DCIS patients. So a little bit of the background is in 2016, we had these guidelines that told us that negative margins halve the risk of invasive breast tumor recurrence as compared to positive margins. 2 mm minimized the risk and wider margins made no additional benefit. And thirdly, and most importantly, clinical judgment should be used in determining the need for further surgery in patients with negative margins narrower than 2 mm. So what are the concerns with this was that these consensus guidelines were based on group results from 4 studies, 3 of which included historical cohorts dating back to the 1970s. Therefore, is it relevant in the modern era with advances in breast imaging, standardized tissue processing, and the use of radiotherapy? And while the guidelines recommend the use of clinical judgment in smaller margins, many use these guidelines as an absolute indication for re-excision. So coming back to the abstract, it was a retrospective single-center study in which 1,866 patients with pure DCIS undergoing breast conservation surgery were included in the analysis. Out of these, 1,807 patients were in the radiotherapy arm, and the no radiotherapy arm was only 59 patients. With median follow-up of 6.8 years, they compared margins more than 2 mm versus less than and equal to 2 mm. So when we look at the population, two things I would say was if we look at the nuclear grade, most of their patients, almost 90% in the no radiotherapy arm and 80% in the radiotherapy arm, are low grade. And the other thing of note is hormone receptor status. More number of patients were unknown hormone receptors in the no radiotherapy arm, and there was less use of hormone therapy as well in the no radiotherapy arm. Therefore, most of the patients in the radiotherapy arm actually received hormone therapy as well. So while across the board they found no difference, when they divided this into radiotherapy versus not, they found that in the no radiotherapy arm, which is 59 patients, there was a split in the local recurrence. And they concluded that a negative margin of any width is not related to local recurrence in DCIS patients who receive radiotherapy, and routine additional therapy for wider negative margins may only be needed in patients who do not undergo radiation. The limitations of this study, I would say, was that 2 mm margin was also included in the narrow margin. There are only 59 patients in the no radiotherapy arm, and 6 years is a slightly short follow-up in only DCIS patients. Another study presented by Urvashi a few minutes ago compared 17,000 patients, with more than half the patients were high-grade DCIS, and it concluded that patients with margins less than 2 mm have a significantly worse time to recurrence and overall survival. So I think some of the takeaways would be that it is imperative to remember that a recurrence in DCIS patients is likely to be, in more than 70% of the patients, to be an invasive recurrence with a risk of METs, and therefore we should be cognizant of that, and it should be a case-based decision based on other factors like age, family history, nuclear grade, and the presence of comedonecrosis. In our population, we have a younger population with more number of palpable DCIS, which we know is higher grade and more risk of microinvasion. And omission of radiotherapy, for me, in practice, even after this abstract, would be limited to mastectomy and maybe low-weighing NPI patients. And I would be cautious in choice of patients for observation with close margins. Thank you.
Thank you very much, Dr. Karishma Kirti. We now have
Yeah, thank you. Let me just conclude on this. Is one more?
Okay.
Is there one more?
There is a panel discussion and then your concluding remarks. So would you like to give a concluding
These five,
before?
at least we can do
Okay,
a quick
go
run
ahead,
through.
ma'am.
Sure. As I see, I mean, it's a good choice of abstracts that have been picked up. The contentious things being, of course, a DCIS, second is re-excisions post-DCIS recurrence, and then, of course, the ongoing debate of T1 tumors with triple negative and HER2 positive. What really comes as a take-home here is that, obviously, a margin less than 2 mm in any of the DCIS patients still seems to be a contentious one. We continue to take home this message of 2 mm being a margin or more for a DCIS, and a radiotherapy not being given is always associated with a higher recurrence. So that was the take home with the DCIS ones. As far as the re-conservation and a re-DCIS, I don't think it is the re-conservation which is a debate, it is also the re-RT. So as you can see, most of the people who have received radiotherapy would end up with a mastectomy, and those who have not would have ended up with a re-excision. So there again, there is a debate that goes on. As far as the T1 tumors are concerned with triple negative or a HER2 positive, it's very obvious that in these patients, I think surgeons still continue to dominate. Surgery still remains the line of treatment. And of course, in the rest of them, T2 onwards, because of the evidence that is evolving with the extended treatment that is being offered for triple negatives and HER2 positives, the reason to give a neoadjuvant would probably will be increasing now with the available evidence. And BRCA1, of course, breast conservation is the safe option. We have known that for long, and this abstract, I think, just reconfirmed the same thing. Yeah, that would be my conclusion. Debashi.
Thank you, Dr. Vani Parmar, for summing it up. I would now like to call upon Dr. Neeta Nair as a moderator for the panel discussion. Dr. Neeta Nair is Senior Surgical Oncologist at Apollo Hospitals, Mumbai. And I'll quickly call the panelists. Dr. Makarand Bhole, who is a surgical oncologist in Mumbai with special interest in BCS. Dr. Sumit Shah, who is a consultant surgical oncologist. Dr. Shilpi Dolas, who is a consultant breast oncoplastic surgeon at Ruby Hall Clinic and Jupiter Hospital, Pune. Dr. Nitin Tate, who is a consultant surgical oncologist at Adyan Hospital, Aurangabad, worked as a senior research fellow in breast surgery at TMH. Dr. Naveen Kasliwal, a surgical oncologist working at Aurangabad. Dr. Vaishali Zambre, who is a senior consultant and unit head breast cancer surgeon at RGCIRC, Delhi. Dr. Arun Goel, who is the Senior Director, Surgical Oncology, Max Super Speciality Hospital. Dr. Garvit Chitkara, who is a Senior Consultant, Breast Surgical Oncology, Nanavati Max, and a previous Associate Professor in Breast Surgical Oncology at TMH. Dr. Vani Parmar, ma'am, will you also be please coming here? Ma'am is a Chief of Breast Surgical Oncology at Punyashlok Ahilya Devi Holkar HN Cancer Institute of India at Mazgaon, Mumbai. And she started her second innings after 25 years at Tata Memorial Center. Over to you, ma'am.
Thank you so much. So at the outset, very grateful to MOC and all the organizers for this opportunity. Special shout out to Jay for putting this group together. We've heard all our presenters with the abstracts. We're just going to take this through to more of a what are you going to do on Monday morning for the data that you've heard. So I think the most exciting, and I'm going to get some of the medical oncologists in the audience to chime in because we've all got surgeons and we know what that voice is going to say. For stage 1 early breast cancers, which are TNBC and HER2 positive, we are all talking about an increased use of neoadjuvant chemotherapy. And this is, of course, based on data, which I think we've all talked to death, not for any specific reasons, but the obvious prognostication of tumors, and of course allowing us to modify treatments after that in the adjuvant. Surgery does become a little tougher in these patients. Often we're doing only clipectomies, 30% of the nodal staging is inaccurate. And what I'd like to go, and I'm going to start with Naveen from that end, what is your current practice for anyone who presents to you with early breast cancer, amenable to breast conserving surgery with triple negative or HER2 positive disease?
As a standard, HER2 positive should ideally, by what we practice now, goes for an ACT.
Fair enough.
But generally speaking, if really small early patients, nothing averse in going for a primary surgery.
So we're still doing either or with that.
Yes.
We just go down that. Makran, your take on that.
Dr. Neeta, may I just interrupt? May I call upon Dr. Urvashi Jain to please join the panel on stage? Thank you. Sorry.
We're going to get Urvashi's opinion last on this as the international word on it. Go ahead, Makran.
If it is a small tumor, obviously I'll operate first and then send.
And your medical oncologist sends these patients to you? That's my question. All right, Shilpi. Let's just go down the whole panel, get everyone's views across the state as to what's happening.
I would like to add few things actually. If it is a small tumor, but I look at the age of the patient also, the grade of the invasive cancer, how much is a grade, whether it is grade 2 or grade 3. If it is grade 1, I'll operate.
Most TNBCs
Yes.
and HER2s are going to be grade 3.
Yes, but sometimes they'll come grade 2 also, ma'am. So age of the patient also matters. If the patient's age is more than 50 or more than 60, then I would like to operate. And if it is in between 50 to 60, I'll take a call according to the HER2 and TNBC and discussion with the medical oncologist. Sometimes whether they have another comorbidities or not, because later on they have to take the chemotherapy. Only one hand is available, or otherwise we have to place the chemo port in them.
Fair enough. Sumit, your take on this.
So, I do a PET CT in almost all my patients, though it may not be required for an early stage, but I have coordination with my 2 people who do the PET and I try to see the nodal burden. Most cases less than 2 centimeters may not have lymph nodes, so less than 2, I would probably operate upfront. But if I see the nodal burden there, of course, then
Fair enough.
N plus. Then
Nitin,
send
your
for-
take.
Usually less than 2 centimeter upfront surgery only unless tumor is upper outer quadrant close to axilla. In that situation, I like to see whether lymph nodal involvement is there.
Fair,
Or not.
perfect. Point well taken. So just for anyone in the students in the audience, what Nitin's trying to tell you is that you know that with the outer quadrants, and especially extreme outer quadrants, your probability of lymph node positivity increases. So you have to take that also into mind when you're planning surgery for someone who's node, a 2 centimeter tumor. You can't just assume just because it's 2 centimeters, it's not going to be node positive. Vaishali, your current stand.
So in addition to the other factors, I would also like to understand the financial status of the patient and the level of understanding, because many of the times when we discuss both the options, the patients tend to get confused. So rather than confusing, if it is a very early disease, node negative, I would rather operate first and go ahead.
So,
yeah. So for T1 or N0, basically clinically and ultrasound assessed, I offer surgery. It is T2 or node positive, then we definitely offer neoadjuvant therapy. But there are some patients who are not willing to accept, then we are comfortable going ahead with surgery in case the patient says, I am not going to take.
fair enough. But I'm going to ask you that again. If the patient reaches your medical oncologist, how many times does that T1 N0 also come to you in your institution?
No, at least in my setup, they always discuss
So
with us.
excellent. Garvit.
This is the third time I'm answering the same question since yesterday.
To answer
But
that.
T1 N0 surgery, T2 or N plus neoadjuvant chemotherapy, and obviously logistics have to be considered where the patient is traveling from, what is the status of being able to take TDM1 or pertuzumab cost-wise, if it is going to be only trastuzumab for her to know upfront, otherwise.
So fair enough. You're taking factors into consideration, and that's for T2 N plus, not T1 N0s. Madam, any difference in opinion?
Not much. It's just that T1 definitely a surgery first. If it's a T2, early T2, I would still consider a surgery. But if it's a later T2, a larger tumor and a node which is clinically positive and large, I would give a neoadjuvant and consider in view of the adjuvant data.
Fair enough. Urvashi, last take. What is the current practice in the UK?
So the contention is always with the T1Cs really. And the whole matter of the fact and debate is really about de-escalation. For me, it's quite clear there has to be either de-escalation of surgery or de-escalation of chemo. If there is a benefit in terms of de-escalation of surgery, then yes, that is where we have a heated discussion in the MDT. But if there is going to be no de-escalation of chemotherapy...
So what is the current practice in the UK for a T1C TNBC?
It's varied
Okay,
within
fair
MDTs.
enough. So just to be clear that the debate is international, and I'm going to just get 2 medical oncologists. I can see Sumit sitting right in front of me. What is your current practice with T1C tumors? Can we get that mic on, please?
Yeah, again, I think it's very heartening that we all discuss multiple factors to take into consideration. But yeah, I would refer personally to upfront surgery. But if yes, in very aggressive tumors, TNBC, young patients, we can consider NACT. Yeah.
So, Pranjali, short, quick one. We need to jump to the
Just
next
one
one.
quick thing, the TNBCs, young patients that need genetic testing, sometimes I will do just
So
get
if
time
your
for
patient
genetic
is
testing.
even 2 centimeters,
Yes.
you choose to give
Yes, I will
NACT
clip
for
it,
that.
and
So we're going
sometimes
to
I
come to that question further down, just to answer that. Now, we've based all of this on the 3 standard trials that we discussed, CreateX with capecitabine in the adjuvant for TNBCs, Pembro in TNBCs, and of course, HER2 and TDM1 in HER2 positive disease. What I think is fascinating, and I'm glad this got discussed at San Antonio and the educational session, is look at the representation of T1 and N0s in these groups. And that's really, really minuscule. So for us to be able to say that we're using de-escalation as the option, one is surgical de-escalation is not necessarily going to be achieved because you would have already possibly been able to do breast conserving surgery. We're fortunately not there yet for no surgery in TNBCs and HER2s. And that brings us to what is the benefit with additional adjuvant therapy. And if you see capecitabine, both in T1s and node negatives, had no benefit in CreateX itself. Another topic that I think Neha alluded to very well was that you reduce ALND in that. But of course, we know that we're all struggling with post-chemo axillary conservations. We want to be able to stage them more correctly. And I'm happy to say that the new year has brought a slight change in that, in us being able to say T1C is not necessarily something as clear as we would do for T2s and node positives. T1C and especially N0s, I think the data today is lacking to be able to say you have to offer it. The debate does continue. And I think our panel very eloquently mentioned factors that they would consider where they would want to escalate. So I'm going to say that for anyone who wanted to be able to give this, does this convince your practice change on Monday morning? Anyone in the audience who's always giving T1Cs neoadjuvant chemotherapy, would you now change to surgery? And since we're a heavy surgical audience, the person I'm going to ask is Vivek, who though most of his decisions may be arm-wrangled by his wife. So let's say Neha's not your referring breast surgeon. Vivek, what's your take for Monday morning?
So I think, ma'am, everyone mentioned it correctly that I take it very simply. T1 N0 has to go for surgery, and T2 or N node positive happy to give neoadjuvant.
So I think that's a very clean answer, and I think that's what our take-home should be. We need to stop hesitating to operate T1 N0s, even though they are TNBC and HER2, and be able to do good surgery for them. So just to take forward to the next question, which is what Pranjali mentioned, that she'd like to give a T1 N0 chemotherapy in a young lady, be able to do check for BRCA testing. So what was interesting about this study, and I think Purvi mentioned most of it, so I'm going to jump across that, was that you did see a difference, and unfortunately the unilateral mastectomies looked to be worse, but that's, I think, heterogeneity of the data which she brought out. So more to the effect of, I'm going to ask Dr. Goyal this, is what is the actual incidence or positivity of BRCA positivity in our Indian population? Do we have numbers on this? Do we have any, so Dr. Arun Goyal, your take on that?
From my personal practice, I cannot give statistics like this, but the thing I would like to quote is the AIMS publication, which was there, and it was a consecutive series. So overall, the proportion of inherited mutations is definitely higher in an Indian series. So overall, we are now, like, a lot of our patients are not accepting genetic testing.
Correct.
But we do find from time to time BRCA1, BRCA2, and some of the rare ones.
So I think what's made it easier is access to genetic testing, also access to the fact that we get reports a little earlier now than we used to in the past. So does everybody, for someone with significant family history and a TNBC, like Pranjali mentioned, wait for a genetic report and start NACT irrespective of stage, or are you happy to go ahead and operate? Sumit, your take on that in practice?
Yeah, a vast majority of TNBCs which I see, most of them are anyways more than two. I mean, they are T2 or N plus or something, so I'm bound to send them for chemo.
But let's say you get someone, fortunately, with an early tumor.
Yeah, then I will probably operate a BCS.
So happy to go ahead and do a BCS
happy to
with
go ahead
that.
with surgery.
So anyone else with the same take on wanting to wait for BRCA positivity would want to be able to justify needing the need to wait? So we all do that. A lot of us, for T2s, for N node positives, we're all giving chemo, we're all talking to them about waiting for genetic tests. How many of us are also going to do that for all comers? So Urvashi, your take on that?
It's usually a discussion with the patient when it's a triple negative young patient for genetic testing. We do genetic testing for all patients below the age of 60 with a triple negative breast cancer. And with the advent of all the systemic options that are available, apart from just having to offer risk-reducing surgeries, the medical oncologist will also be on board for us to wait and discuss that with the patient and then approach it the best way possible.
So just one take, and maybe we just go down the panel. Is everybody happy to offer breast conserving surgery in a BRCA positive patient? We'll start with Madam and go down the thing.
Yes.
Nitin. So no concerns. Shilpi, we'll continue down with you. Any difference in opinion? So is anyone in the audience against breast conserving surgery for BRCA positive patients?
Been bilateral mastectomies.
No, so but if your patient is amenable for a breast conserving surgery, says I do not want a mastectomy, is that wrong? Would you not do it?
I would inform them of the data, and if
That's
they still
fair
want
enough.
it, I'll do it. But
So, sorry.
So can I just make one comment
Please.
on the thing? So the same thing that you're talking about, the data said what? The data only says the incidence of contralateral breast cancer comes down because there is no contralateral breast. So the incidence will come down. Does it improve survival? It does not improve survival. So we have to give them patient the information saying that we will do a bilateral mastectomy, but you may not do better than the breast conservation surgeries.
you will not.
That is the take home from this data.
No, so I get what Pranjali is trying to say is that you don't have to take treatment again, which is not something that we're completely so I agree with the conversation needs to happen with the patient, but I don't think the fact of waiting for the report is what we would change our treatment for, is what the panel is trying to say. Yes, Namita.
Yes, for the discussion part, it's very nice, but I often face this thing when I'm practically talking to a patient. Why are we doing the germline mutation test then? When we know that we are going to save the breast, when we know that the overall survival is not, there is no difference, why are we going on giving the bad news to the patient? Though we know when the report comes, we are then again going to counsel the patient that yes, you need not undergo the bilateral prophylactic mastectomies. Then why are we doing these
But
tests?
I don't think it's just surgery for the breast. It's a lot of other factors. You'd want to discuss an oophorectomy later. You'd want to discuss olaparib. Your surveillance changes with the use of an MRI. You can discuss prophylactic procedures 2 years down the line when the biology dictates, it sort of defines itself.
So that can be taken care of even post-surgery.
No, completely. So that's what we're trying to say, that no one's waiting for the report for BRCA-ness to be able to plan treatment for someone who's amenable to upfront surgery. That's the point the panel's making. Yes, please. Can we get that mic on, please?
Hello. Yeah. The paper which I presented is the conclusion was that doing contralateral mastectomy reduces the risk of contralateral breast cancer. That is well understood. And if we don't do the contralateral mastectomy, then if recurrence happens, then the survival is reduced. So isn't it logical that if you do mastectomy, then you're
yeah, but if
reducing,
you see the no, but if you
risk
see
of-
the multivariate analysis, there's no difference in death,
it's
in survival. So I'm going to tell you that, and Purvi did say this in her presentation, this is very heterogeneous data. Everyone who had a mastectomy had heavier burden disease, higher grade tumors, larger tumors. This is not a comparison which is a propensity matched analysis. You're never going to see randomized evidence to this effect in terms of bilateral versus unilateral versus BCT, but this paper requires a lot more information to come out when it gets published for us to be able to actually be able to answer a lot of the questions that it dropped up. The paper seems to suggest that unilateral mastectomies are worse to do than even a BCT, and that the outcome in terms of death for a unilateral analysis or a univariate analysis is worse for a unilateral mastectomy. And I think that's biased by the other treatments, which is exactly what Purvi brought out.
Can I just add something, Neeta?
Sorry, just let him finish.
We cannot quote this paper in for counseling of the patient.
Not
Because,
yet.
Yeah,
I
because
don't
we
think
know
so.
that doing contralateral mastectomy
I
reduces
don't
the
think
risk of
this
death.
paper,
And in
the
the same breath,
abstract
you are saying
something.
it will not improve the survival. It should.
No, so which is what we are saying, that there are a lot of pitfalls to this current data, and the presentation requires something. Yes,
Can I
Dr.
just
Vani.
add one more comment? Now, if you just look at the numbers even in this paper, because this is what we are discussing right now, 40% had unilateral mastectomy, nearly 40% had BCT, 20% had a contralateral mastectomy, right? That is the data that is there here. But the 40% that was weighted towards an unilateral mastectomy had larger tumors, did not get the treatment that they were supposed to. Even their adjuvant therapies were not to the tune to which they should have received. So there is a problem here with the treatment of the unilateral mastectomies itself. These are biased patients. Now, if you look at these and you say that no, the contralateral saving of the breast caused a negative impact, it's not. It is actually the fact that this disease was already a higher grade disease and poorly treated breast cancers. That is why there is a weightage towards contralaterals having a poorer outcome, and that is a data that's a put together data. That means
So, sorry,
conservations as well.
last comment and then we're moving topics.
Yeah, I think that what Dr. Vani said, firstly, because it's retrospective, so there is a significant selection bias between the patients who are having mastectomy versus those who are having BCS. That would be in part responsible for the poor outcome. Secondly, the survival difference for contralateral recurrences was breast cancer specific survival. When the overall survival was compared, there was no difference. So
Correct.
that also we have to
So
consider.
again, point well taken is that there's a lot of heterogeneity in the paper presented, and I think we would need to wait for the final paper for that. We're going to move across to DCIS, and I think the one thing that needs to be said is all three of these abstracts primarily discuss screen-detected DCIS, which I think, fortunately or not, we have not started seeing as often in our population. I can see Urvashi smiling there, big and bright, but fortunately that's not a problem we're seeing. And I'm going to actually ask Naveen and Nitin, who do a lot of practice in the state of Maharashtra, and they've been at it for years, is what is your current practice in screen-detected DCIS? How many are you seeing? So Naveen, you can start.
Yeah. As you said, screen-detected DCI is really rare. We usually have palpable DCIs, and we are not averse at doing a conservation surgery for that.
Perfect.
Only if we are following it with radiation.
Nitin, any difference?
Yeah. So far, I have done only 2 localization and excision for screen-detected DCIS.
In how many years
in
that
8
you've
years.
been? In 8 years. So that's the point being
most
made.
of them are palpable. Invariably, I get microinvasion. And I remember 2 people presented with nipple discoloration, multiple biopsies, and then presented. So it is not very common in our practice. And yes, I have done BCS, and in 2 patients, I needed to do re-resection of the margins.
Sumit and Arun Goyal, sir, you all have been in private practice now for what, 10, 15 years, if not more? So I'm going to ask you, in this span of your practice, how many screen-detected do you think you see? Sumit, you can go first.
Yeah. Screen-detected DCIs, I mean, not much in my practice.
Fair
in
enough.
spite of it being in Bombay, but of course, I'm in a very smaller center and a smaller area.
Small or
so-
big is the same. It's about the thought process in the city. And Dr. Goyal with Delhi's practice, none at all.
No screen-detected
So
DCIs.
fortunately for us, it's still not something that we are struggling with. But despite that, we do see a lot of palpable DCIs. We need to take in mind just what Nitin mentioned, is that we see a lot of high-grade disease and we see more micro-invasion. That needs to be kept in mind. So for this set of patients, which the abstract discussed, is fewer had received original RT. Most of them were older. They were all lower risk. And we were able to say that local recurrence following IBTR treatment in reconservation was obviously higher, but there was no difference in terms of outcome. And we said that we could offer re-BCS. So my question here is, for the current scenario that we face in India, if you have a patient who's treated with a BCS done for DCIS, your patient gets a recurrence, how often are you going to be able to, based on this data, now Monday morning be able to offer this patient reconservation surgery? Anyone on the panel? And then we'll end with Urvashi, who I'm sure sees this often enough. So Dr. Vani.
Want me to say first? Okay. So as far as I could take from this is that the concern is not a reconservation, the concern is a radiotherapy. I think it's the radiation oncologist who will not be comfortable with doing a re-radiation for a pre-radiated breast, one. Secondly, looking at these patients, if you can, if there is a long DFI that you have, then there is a possibility of doing a re-radiation.
So we are
if
discussing
in the first
the
sitting.
optimum situation where it's all possible. Are you today for palpable DCIs that comes to you,
No, in
comfortable
palpable
to be able to do
DCIS,
it?
yeah, the whole scenario changes. I would be more comfortable doing a mastectomy, not a reconservation as far as possible.
So Dr. Goyal.
Yeah, The problem with the re-radiation is that in this series, only 5% of patients actually had both primary and secondary, and 40% of patients had primary radiation. Unfortunately, in India, if we see our series, nearly 95 to 98% of patients have received radiation after they have undergone BCS. Maybe because we all have symptomatic.
Correct. So that's the point being made, is that exactly what Karishma pointed out in her study, is that we currently follow VNPI to be able to say whom we'll avoid radiation in, which means that the patient has probably had a mastectomy or is low risk, low grade tumors, which we aren't really seeing very much of. So most of our patients who've had primary surgery will have had radiation for a breast conserving surgery, and then we're discussing the possibility of re-irradiation. So Urvashi, last take on this, and we'll move to margins.
The patients that have initially presented with low-grade disease, and I'll make a very simple statement. Anybody who's eligible for an APBI can have a re-breast conservation. And I would say watch the space for data coming from MSK, from Dr. Cody, and Philip Portmans from Belgium, who are specifically looking at this in a couple of years.
So I think low risk, low grade DCIS seems to be seeing more change. And I think it's work we're generating out of screening, but that's a personal note. So we've got the last two abstracts which discuss something on margins. Our current practice for negative margins is 2 millimeters for negative DCIS margins. Most of us opt to revise rather than radiate. But what's interesting with the studies is that one of the studies was based on the American College recommendations of 2 mm and one on the UK recommendation suggesting that even 1 mm was an option. We heard both our speakers between Urvashi and Karishma discuss the abstracts. Interestingly enough, one is much larger in terms of the population that it covers, but it did have less than 2 mm margins in only 20%. The aims in both were different in terms of any margin width versus negative margins, and of course there was differences in radiation and treatments offered. Even though the single center study did suggest that you could opt to radiate only in patients who are not getting radiation revised margins, the other paper clearly seems to suggest that 2 mm margins would be required. So I'm just going to take it down the panel, starting from Vani Madam, ending with Urvashi, on Indian data versus what's happening in the West, as are we willing to change our margins Monday morning?
No, I think I'll still stick to my 2 millimeter margin for DCIs.
Same 2 millimeter margin.
No, I'll not revise it down. But if it is, say, in some cases post-operatively negative margin but less than 2 mm, then not every patient I am going to do a revision surgery.
I would take that as I would also look at other factors like EIC, how many margins, and then discuss that. Any difference from the panel?
So the burden of the
DCIS on it. Urvashi, any last takes on that?
Stick to 2 millimeters at all points. With DCIS, I would say if there is an isolated, non-contiguous foci on a margin, and if it's less than 2 millimeters, we don't need to go back in. But if it is contiguous, and if it's on a broader margin, then yes, definitely re-excise. In the West, however, now high grade and low grade are going to be treated as completely
different
separate entities. And Karishma very nicely highlighted the abstract that she presented, where 90% of the patients had low-grade DCIS, and hence those results.
Correct.
We're looking at no surgery and no radiotherapy. Forget revising margins or no tumor on ink.
Right. So if I have permission from the chair, we have a question from the audience. Go ahead.
Just quick comment was, pure DCIS is not always palpable or screen detected, oftentimes seen in microdocectomy patients who come with bloody nipple discharge. And those are the ones...
That's palpable, symptomatic.
Yes, but all three recurrences that come to mind in my practice have been in these patients, and before I re-excise for margins for pure DCIS, I always get a breast MRI because I want to know if I'm re-excising, am I re-excising that for that 1 or 2 millimeters? Or is there disease everywhere that is going to be high-grade
So I think
DCIS
that's a
and never
debate
missed?
for another day, for the fact that some of the concerns that one needs to look at is how dense that mammo was, whether it was calcific DCIS or non-calcific. So I think that's something that, yes, each of us changes in our practice based on that. And if we have any questions from the audience, we'll start from there. And okay, that seems to be our only question in the audience.
We are running out of time. ma'am.
Last
We've
question and we're
exceeded.
done. Thank you.
So 2 millimeters is fine. I
Yes,
understand the
Ajay.
panel saying 2 millimeters. But what do you aim at when you're
So
operating?
your aim is at least 2 millimeters. So I think what most of us are fortunate, and I'm going to say this and I'm going to let anyone in the audience correct, the panel correct me, is when you have palpable disease, you're holding the tumor and looking at 1 centimeters beyond that and excising that, because your risk is microinvasion, your risk is additional disease, like she mentioned, of skip lesions. You want to be able to have achieved at least 2 millimeters microscopically. Are you trying to achieve 2 millimeters when you're excising? The answer is no. Because it's palpable disease. The discussion happens differently when it's screen detected or impalpable disease.
Yes. So what I'm saying is, if you
Sir,
have a diagnosed
can you carry
malignancy
on the
versus a
discussion?
DCIS,
Sorry.
proven malignancy versus a DCIS, do you plan a different margin?
No, so the answer is no to that. So we can take that discussion forward in tea, if we get a tea break,
Yes.
which I doubt is happening. So thank you very much.
May I-
Very grateful.
Yeah, may I request all the panelists to be on the stage? We are having a group photo, and like to call upon Dr. Debanshu Bhadri also on stage for a group photo, and all the speakers, Dr. Neha Chaudhary, Dr. Namita Pandey, Dr. Urvashi Jain, she's there, Dr. Purvi Thakkar, and Dr. Karishma Kirti. Thank you, all the faculty. We move on to precision oncology in breast cancer. And to chair this session, I would like to call upon Dr. Devendra Pal, who's a senior medical oncologist at MOC Panvel. Before I hand over the session, my sincere request to the speakers and moderators to please stick to the time. I would like to call upon Dr. Anup Kumar Rao. Dr. Raul is working in the capacity of Associate Director and Senior Consultant Medical Geneticist at MedGenome Labs, Bangalore. So you've got 5 minutes.
Thank you. Hearty good morning. First of all, thanks to the organizers for having me here. So I'll be presenting this study which was presented in San Antonio Breast Cancer Symposium, a longitudinal neoadjuvant and postoperative evaluation of ctDNA in early breast cancer.
May we have the people in the hall please carry out your conversations outside so that we can have uninterrupted sessions here. Thank you very much.
Thank you. So, patients with early breast cancer, it's enigma. Diagnosis, neoadjuvant treatment, what to go about and how to go about, right? So, what was so unique about this study was, firstly was the technique in which they did the analysis of, excuse me, why is the slide moving? Yeah. So most importantly, what was so unique about this study was the way in which they did the test. One is baseline, followed it up in cycles post-surgery and monitored it continuously over a certain duration of time till the time the patient was available for follow-up, maximum being median follow-up being up to almost 4 years. Next is the technique of the study. So routinely we do liquid biopsies or we pair it up with tumors. Here what they did was they did the tumor whole exome sequencing as a baseline. Then they did the liquid biopsy. They did the ctDNA whole exome sequencing. And in parallel, they also extracted the Buffy code. That is, they did the germline whole exome sequencing for the patient. So 3 studies in one. You have the data, you have the germline data, you move out or rule out or remove the confounding variants or genes that you have found in germline, or which could be not important from your, this could not be a true representative from your tumor. You know what is coming from tumor and what is germline. So that was important in the study. And the uniqueness of this platform was the ability or sensitivity to detect the abnormal variants. The sensitivity was to the limit of detection was 0.001%. That means they were able to detect 11 abnormal haplotype genome in a concentration of 1 lakh haplotype genomes. That is pretty high. Can you go to the next slide, please? So what they found across the tumor subtypes, the overall detection rate for liquid biopsy for all tumors was 77%. For HER2 positive, it was 70, maximum being for TNBCs, where it was almost 90%. And they were also able to demonstrate the overall relapse-free survival, which was significant in the patient cohort where the ctDNA values were negative. Yeah. And the median lead time was 152 days before the actual relapse that was detected. So to conclude, this platform was highly sensitive given its limit of detection. Baseline ctDNA rate, it varies depending upon the hormonal subtypes, whether it is hormonal receptor positive, TNBCs or HER2 positivity. This baseline detection was associated with clinical grade but not other baseline variables. And this is persistent ctDNA detection midway through NAT is prognostic of clinical recurrence in HER2 positive and TNBCs, as was demonstrated. So the point is sensitive assay like this RDR could be utilized in clinical practice. So one more point which I missed earlier due to the slide discrepancy was, this assay was individualized for each patient. So that is, once they did a whole exome sequencing, they developed a primer-based assay for ctDNA based on 48 markers for each patient in a span of 4 weeks. And that was when they were ready to take a liquid biopsy sample where they sequenced the Buffy code, that is for germline, and the ctDNA. And the reporting time post that was 7 days. So almost in a span of 4 weeks from the biopsy and another 1 week, they were able to give the liquid biopsy reports with the genomic markers in the ctDNA. And this could also be in future utilized for prognostication, looking at the variations that occur at the molecular level in the ctDNA. Thank you.
Thank you very much, Dr. Anup Kumar Rao. With great pride and pleasure, I invite Dr. Krishna Chaudhary, who has been my student. It's a pleasure to introduce you. Dr. Krishna is a consultant medical oncologist at MOC Indore.
Thank you so much, ma'am. So good morning all. I am going to present a very interesting data. It's a retrospective data which is hypothesis generating, and it's regarding tumor infiltrating lymphocytes as a predictor of pathologic complete response to neoadjuvant therapy in HER2 positive breast cancer. So the purpose of this study was to study association between tumor infiltrating lymphocyte expression with the pathologic complete response following neoadjuvant therapy in Mexican patient in HER2 positive breast cancer. Retrospective cohort of patient with stage 1 to stage 3 HER2 positive breast cancers were received neoadjuvant therapy between 2017 and 2020 at Institute of National de Cancerologia, and they collected a demographic and clinical pathological characteristic. So univariate logistic regression analysis was done on multiple factors initially, and those who were found significantly on those, the multivariate analysis was done, and their association with the PCR they tried to find out. So here the definition was tumor infiltrating lymphocyte levels were different. Low was 1 to 10%, intermediate was 11 to 40%, and high was more than 40%. Here they did the tumor infiltrating lymphocyte assay with microscopy and H&E staining, which was not done on any other platform, but simple H&E staining. So in this diagram, first chart on your left side, they did the univariate analysis on multiple factors. And on your left side is a multivariate analysis. So those factors who were found significant on univariate, they did the multivariate analysis. Multivariate analysis mimics the more real-world scenario, and it is more important. So on multivariate analysis, among the multiple factors, they found out that tumor-infiltrating lymphocyte levels were significantly associated with the pathological complete response. And also, dual anti-HER2 therapy was significantly associated with the pathological complete response. The figure in the middle, it is very interesting to see that patient who had high or intermediate TILs level got a equal level of PCR, while patient with low TILs, the dual anti-HER2 therapy gave equivalent amount of PCR as compared to single HER2 blockade. So this is a hypothesis generating, whether if we have low TILs, should we use double HER2 blockade or single HER2 blockade. So this was one factor. So these 2 points, that high or intermediate TILs levels, they are significantly associated with the PCR. And another factor is dual anti-HER2 blockade in patient with low level of tumor infiltrating lymphocytes. So these are 2 hypothesis generated points. So in conclusion, in patients who received neoadjuvant therapy for HER2 positive breast cancer, TIL expression was associated with PCR. Patient with intermediate high TIL expression had high PCR rate, irrespective of choice of neoadjuvant therapy. So here is the point of de-escalation, whether we should de-escalate. And PCR rate was significantly lower in patient with low TILs expression who did not receive dual HER2 blockade. Next step, these findings require confirmation in larger prospective studies before implementation into routine practice. If confirmed, TIL expression could be incorporated into decision making regarding escalating or de-escalating of neoadjuvant therapy, especially in the resource limited setting. Thank you so much.
Thank you so much, Dr. Krishna Chaudhary. I now invite Dr. Hani Parekh, who is a consultant medical oncologist at V-Care Hospital, Surat, with 7 years of experience.
Good morning, everyone. Topic is genomic and transcriptomic profiling of primary tumors for patients with HR positive, HER2 negative, node positive, high risk early breast cancer in Monarch E trial. As we all know, patients with node positive early breast cancer are at high risk of recurrence, around 30% at 5 years. In Monarch E trial, evaluation of addition of 2 years of adjuvant amibaciclib to endocrine therapy in HR positive and HER2 negative node positive high risk EBC was seen. It is the only adjuvant study designed exclusively for patients with high risk EBC, and at the pivotal 5-year follow-up milestone, amibaciclib combined with ET has shown increase in absolute IDFS and DRFS rates at 5 years compared to 2, 3 and 4 years rates. Here we evaluate comprehensive molecular profiling of archived primary tumor tissues and associate it with clinical outcome from Monarch E trial. Biomarker subset patients selected using case cohort design. Out of total 5637 patients, 1400 tissues were archived, and amongst those 1173 were whole exome sequencing and 1190 was RNA sequencing. 3 subsets were evaluated basically, which were molecular subtypes, the luminal A, B, basal and HER2 enriched, risk predictor RNA expression based on oncotype score and biomarker mutations and copy number variations. Patient characteristics in biomarker subset were similar to those with intent to treatment population. Amibaciclib benefit was consistently observed in biomarker subset of Monarch E. Looking toward the intrinsic subtype distribution, in all the intrinsic molecular subtypes, abemaciclib plus endocrine therapy was beneficial than endocrine therapy alone, with interaction p-value of around 0.621. In oncotype risk scores, in both the arms, the high-risk patients were almost equal, which was 28% in ET alone arm and 29% with amoeba plus ET arm. And here, the tumor percentage of tumor with more than 25 risk score were reflective of high-risk patient population. Here also in both the arms, either less than 25 score or more than 25 score, amoeba-ciclib plus endocrine therapy was beneficial than ET alone arm with hazard ratio of 0.59 and 0.73 subsequently. Looking towards the prevalence of oncogenic mutations in copy number variations, in all the prevalent genomic alteration like mutation, homozygous deletion, there was benefit in amoeba-ciclib and ET arm. However, in MYC amplifications, the association was diminished in this amoeba-ciclib and endocrine therapy arm. To summarize, transcriptome analysis demonstrated consistent amoeba-ciclib benefit on pre-selected signatures across all the intrinsic molecular subtypes and in both high and low risk scores using inferred oncotype RNA signatures. It was beneficial even in most prevalent genomic alterations with exceptions to MYC amplifications. Further confirmation of this exploratory results is needed. Future work will include integrating further exploratory and more comprehensive genomic and transcriptomic analysis with clinical outcomes from Monarch E. Thank you.
Thank you very much, Dr. Hani Parekh. I would now like to call upon Dr. Chirantan Bose, who is the head of the Department of Precision and Molecular Oncology at MOC.
Good morning, everyone. Continuing, I think, in the precision oncology section, this is the last topic. So I'm presenting the cohort E results of the plasma match trial, which evaluated circulating tumor DNA in a dynamic change across patients of triple negative breast cancers in response to PARP inhibitors and AKT inhibitors subgroup. So just to show you what the plasma match trial consisted of, it divided the subset of patients of about 2,000 total group into 5 subgroups. The cohort A was based on ESR1 mutation, B on HER2 mutation, C on AKT1, D with AKT1 hormone receptor negative and PTEN, and E for the triple negative breast cancers, which we are going to see today. So the hypothesis was that early changes in circulating tumor DNA can help to predict patients who will respond to the treatment even before imaging changes appear. This study reported a baseline and early on treatment ctDNA analysis on the cohort E. Circulating tumor DNA ratio was calculated, which was the ratio of ctDNA on the cycle 2 day 1 to the level of cycle 1 day 1, pre-specified against the weighted average mean of the variant allele frequencies that were considered here. So if you see, starting with 75 patients who were totally enrolled in cohort E, about 21 patients were excluded because of various criteria, leading to 53, out of which 2 failed paired DNA sequencing, and finally there were 51 evaluable patients. This is the result where, so just look at the Kaplan-Meier curves. The first one shows when the cutoff of the circulating tumor DNA ratio was 0. So 0 against any elevation, and there is a good separation between the responders and non-responders. Whereas in the lower Kaplan-Meier, you can see that the ctDNA ratio was changed according to the baseline and the mutant allele frequency, where also there is a good separation, but the separation is less. If you see on the chart, you will see that this consists of various different BRCA mutated and unmutated, which is admixed across the responders and non-responders. While in the cohorts A to D, there was a clear separation between the responders and non-responders. In the cohort E, you will see that there is no statistically significant difference between the responders and non-responders. Hence, the study concluded as clearance of the ctDNA to become undetectable by the cycle 2, day 1, identified sporadic triple-negative patients who benefited from olaparib and ceralasertib, but ctDNA assessment may differ between therapies and which comprise of drugs with different mechanisms of actions. So implementing ctDNA dynamics into clinical trials and also into clinical practice requires distinct understanding of mechanisms of different therapies and their impact on the circulating tumor DNA dynamics. Thank you.
That's it?
Yeah.
Thank you very much, Dr. Chirantan Bose. I'll request you to continue being on stage as you are the moderator of our next panel discussion. And I would like to call upon the panel, Dr. Kaushal Patel, Senior Consultant Medical Oncologist from Surat, Dr. Suhas Agre, who is a Consultant Medical Oncologist at NLOC Chamber, Mumbai, and attached to Hiranandani Hospital, Powai, and Criticare Asia Hospital, Kurla, Dr. Ashish Singh, who is a Senior Medical Oncologist at CMC Vellore, Dr. Anup Kumar Raul, working in capacity of Associate Director and Senior Consultant Medical Geneticist, MedGenome Labs, Bangalore, Dr. C.V. Pete, who is a Consultant Medical Oncologist from MOC Nashik, Dr. Chetan Deshmukh, who is a Consultant Medical Oncologist from Deenanath Mangeshkar Hospital, Pune, Dr. Taha Sejjiwala, who is a Consultant Medical Oncologist from Mumbai, Dr. Krishna Chaudhary, I'll ask you to join the panel as well, and our chairperson, Dr. Devendra Pal as well, sir. You can begin.
We can start. So, and I think the one who presented the first tracer, you presented the tracer. There was another, the TIL study. So I think if we can invite.
The first speaker?
First speaker is there.
Dr. Dr. Honey?
Dr. Krishna.
Dr. Krishna. Dr. Krishna is
no,
here?
No, Dr. Honey, I think.
Honey? Is Dr. Honey here? Dr. Honey Parekh? Dr. Honey, will you please join the panel on stage?
Dr. Ashish Singh.
Dr. Ashish Singh? I had announced his name. Dr. Chetan has also come. You can go
Thank
ahead,
you.
sir.
So I think all these 4 studies which were presented here look into the cellular and molecular layout, especially in context of triple-negative breast cancers. If we look at the tracer study with the radar assay, which was presented by Dr. Anup, I don't know why this is just floating. Can we just hold it so that it doesn't go to the next one?
Can you arrange the or adjust the slide to changing module of it, because it's going on changing on its own. So can you have it as per sir changing it?
Okay, I will just click the pause button then. Yeah. Doesn't work. How do we just hold on one topic? Shall we just
change the animation, na?
Will it work now? Shall I operate from here or you will control from here?
You do it from here. How is it happening?
So,
Yeah.
I think the tracer was one of the largest study published last year with liquid biopsy as a monitoring tool. Presented by Dr. Anoop. So Dr. Anoop, if I could ask you your thoughts on using liquid biopsy or ctDNA in the tumor-informed versus the tumor-uninformed as a MRD or as a tumor progression assay. What are your thoughts on that? Because I think the commercial assays available in the market are mostly the standard assays are tumor-informed. But in India, several labs have come up with tumor-uninformed assays as well, where you can just take a blood sample of a patient and send it to the lab for a ctDNA evaluation to see whether there is response or not. So what are your thoughts on that?
Yeah, so very important question. So just to simplify things, if you're looking at say tumor uninformed assay for MRD, you can do it sequentially, you can prognosticate, that's it. But what about other information? If you have tumor informed assay, you have a baseline sequencing which have been done on the tumor, you know what molecular markers are there. You also have done ctDNA, you know what molecular markers are present in the ctDNA. So going ahead, when you're doing a follow-up sequentially, any new molecular abnormalities propping up, you are able to identify them, you are able to improvise with that information on the management. So any new targets coming up, any new information coming up for prognostication, you can get that information only on tumor-informed assay. If it is uninformed, you are going to face that limitation.
Point well taken. However, in the practice that we all are involved in, I think we see a lot of patients' movement from one center to the other. And it is not necessary that a patient will come at a baseline setting to a particular clinic or particular lab. So, Pal sir, if I can ask you, what is your thought on, say for example, you have been treating a triple negative breast cancer patient who is doing fairly well and is in a baseline setting, and now you want to use, liquid biopsy to evaluate progression. Have you used this in your practice? What are your thoughts?
Hello. Yeah, I've not used it, not started using it till now. I think we are just in the learning curve phase of these diagnostics. Like till few years back, we used to say that like if patient is off treatment and like patient has like some disease which is evolving but not yet become symptomatic. Like sometimes like now also in CA ovary, we can monitor the patient who is post-treatment by CA125 and regular examination. And so we see that like even the disease is evolving and like maybe if little bit CA125 is there, some disease is there. And there's no advantage of starting treatment much early in the course of clinical course. So if we correlate that in these scenarios, like even if we diagnose, like if we come to the conclusion that the ctDNAs are rising and patient is likely to relapse, do we need to start the treatment now? So I think only time will tell whether we are wiser in starting the treatment on the basis of ctDNA or not. So maybe like over time we'll come to know, but it's good learning, it's learning curve.
Sure. The one factor of baseline evaluation is to assess clonal evolution of the tumor. So for example, there is a breast cancer which in a baseline setting has got a certain mutation, let us say in the PIK3CA. And as the tumor evolves, you may lose the PIK3CA expression and you may gain something else like an FGFR amplification or an EGFR mutation, even in breast cancers. So that helps to see the clonal progression of the tumor and hence can help in the treatment decisions. Moving on, I think if I can ask Dr. Taha, so will only ctDNA, and I think Dr. Pal already alluded to a lot of this, but will only ctDNA fraction? There are some labs which are not reporting the mutations, but only fraction, positive or negative. There is a recent test also available from a US lab, which basically gives just a positive or a negative as an MRD result. So do you think that this is how will this impact in terms of practice for evaluation of residual disease?
I mean, all these things still sound kind of, interesting when you're sitting in a meeting. While practicing in front of patients, very difficult to explain all things. I personally feel that. But till date, I think for us, residual disease is more clinical and radiological. Now, when moving into all these things, it is exciting. If you're able to prove it before we pick it up clinically or radiologically, if you can pick it up on a ctDNA basis, I think we'll be able to pick up disease earlier. But as Pal sir said, whether we'll be able to treat them and will it be effective in long-term basis, still I think we need more studies to consolidate that.
Yeah. So point well taken that, maybe evaluation and use of ctDNA as a prime time, we are there or we are not there, that's a question. If I can come to Dr. Kaushal Patel, what are your thoughts on should be the ideal assessment time post-neoadjuvant, post-surgery and post-adjuvant phase? Because I think the tracer study had got certain timelines. In the paper that I also presented, there was a concept of cycle 1, day 1, and then cycle 2, day 2. So before you start the treatment, what are your thoughts on what should be the ideal assessment times if a patient comes for?
Yeah, so still it's in still it's in learning process. We are not very much sure about the ctDNA or circulatory tumor cells monitoring during the treatment protocols. But if you ask me what is the ideal time to monitor it or to do it after completion of the treatments, then I think at the end of the treatments we should do it to see everything is okay or not, because it's meant only for the monitoring purpose right now, not effective in deciding the treatment changes or to initiate the treatments or anything else. So I prefer to do at the end of the post-adjuvant phase.
Point well taken. So post-adjuvant, at the end of the post-adjuvant phase, but even in the neoadjuvant setting, now there is data, at least for colon cancers, that you can actually extend the neoadjuvant chemotherapy by 1 or 2 cycles before you take the patient for surgery to achieve a better response and a disease pathological remission before the patient goes into surgery. So for breast, I think, as you rightly said, we have to see how things evolve. Dr. Krishna, if I may ask you, have you had any experience with circulating tumor cell, which is the other new biomarker that is coming for MRD evaluation? And what are your thoughts? Should this assay be used? Have you used it, and independently or with ctDNA?
So till now, I have not used ctDNA, but it's coming into solid tumors. Like we can extrapolate from the lung data, where neoadjuvant nivolumab with chemo was used, and they used the ctDNA in that trial, and they found a significantly different outcomes. So I guess it should be evaluated also in the big trials in breast cancer also.
Right.
Just to add
yes,
on,
please.
Two important points. Like there were 2 studies. One was the Rodovish in 2020, and recently a Chinese group has this is in liver cancer. Chinese group previously was in breast cancer. So what they showed was the sensitivity for ctDNA was 78 to 80%. For circulating tumor cells, a bit less, 60 to 65%. But when you combine both, it went up to 90%.
Correct.
And what was important in certain cases where CTC was found to be positive, there were cell-free tumor DNA negative as well. There were cases, and there were quite chunk of it, like 7 to 10%. So that's significant. So combining it makes a lot of sense. Thank you.
Thank you. I think that makes the point that adding these two biomarker or these two analytes together, the CTC count and the ctDNA, has led to new power of estimation of residual disease. And while we discussed of baseline assessments, in practice it becomes very difficult. So when you do not have baseline assessment, the presence of a CTC concentration helps in estimation as a surrogate marker of the disease presence. It is now coined as a new term as a molecular response or complete molecular response and complete cytological response, at least in non-small cell lung cancers. We are yet to see standardization of these assays in breast cancer. Thank you so much. So we'll move on to the second study which was presented. I think this was Dr. Hani's, this was Krishna's. Okay, so we'll discuss on the TILs as a predictor for pathological complete response to neoadjuvant therapy in HER2 positive breast cancer. So we'll start with Dr. Krishna. What are your thoughts on standardization of TIL reporting?
So as per this trial, this TILs evaluation was done on H&E staining only, simple histopath and H&E staining. So it is very much doable in our setting also, I guess. So yes, it means the larger data is needed. This data was retrospective and very small, only 164 patients. So very small data, we need bigger trials and bigger data before we do it. But if somebody wants to do it as a research, it can be done.
Anybody on the house also would like to comment in triple negative or HER2 negative breast cancer patients? There is this international TIL reporting guideline actually, which is from the International Immuno-Oncology Biomarker Working Group, which is freely available online, which I think pathologists who are reporting on TILs use. And it specifically categorizes between peritumoral, stromal, and intratumoral lymphocyte count. It is based on histopathologic H&E stained evaluation. But I'll show you a picture which basically makes the actual practical application a little bit murky. But any of you have any experience in looking at TILs? Yes.
Sayadri, they had done some studies on tumor samples looking at TILs, and there is a heterogeneity within the tumor. So there is more infiltration along the edge of the tumor compared to the center of the tumor. So as a surgeon, when I'm doing an ultrasound-guided core biopsy, if I give you a specimen right from the edge, growing edge of the tumor, you're likely to see a higher TIL concentration. And so I think there is challenges there to, looking at things across the board.
Thank you. Yes, very rightly said. Vascularity and lymphocytic infiltration across the tissue of breast cancer is extremely variable. At some times, some of the tumors are centrally vascularized, and some of the tumors are peripherally vascularized. It is a biological behavior of the tumor growth which differs from case to case. And we look at this as a standard practice when we report perineural invasion in prostatic cancers also, that the zone of the tumor which is infiltrated is extremely variable. Now coming to the mononuclear cells also, this was a paper published in 2022 where they showed actually the splay of from tumor suppression to tumor progression, what kind of mononuclear immunoinflammatory cells are occupied. And while you have the 56 positive macrophages which are gamma interferon expressing and the NK cells on one end, the other end of the spectrum are the more naive macrophages, and somewhere in between are the B cell, T cell component which we consider in the tumor infiltrating lymphocytes. But in histopathologic sections, it's actually quite difficult, and I don't know how many are trained. We don't have too many pathologists here, but to report on tumor infiltrating lymphocytes. One of the other things also I wanted, so this was a paper which came in 2019, which actually prognosticated the application of TILs across. We'll come to that topic. But standardization of TIL reporting is still not present. Second topic which I can come to Dr. Honey, pathological complete response, or actually Dr. Krishna can take it because you actually mentioned about this when you said, so with single agent versus dual agent HER2 blockade in the intermediate to high risk category, so can this be actually used as a marker to differentiate whether you want to use a single agent or a dual agent blocker? And that was the image.
So not right now, sir. You can see only 8 patient and 12 patient in both the dual blockade. So we should not jump and make any conclusion based on this data.
Yeah. Yeah, I think the sample size is very small here, but it does give us some idea that, and there are other papers also actually which I just showed where low tumor infiltrating lymphocytes are actually going on the poor response category, whereas the higher ones are on the good response category, and rightfully so. But I think once the standardization of tumor infiltrating lymphocytes is set, it is definite to become more commonly used as a biomarker in both triple negative as well as in HER2 positive breast cancers as an easy and first-hand tool to histopathology reporting. So the next point, Dr. Honey, is there any difference in the tumor infiltrating lymphocyte patterns in HER2 positive versus HER2 negative tumors? Have you heard about it, or have you seen any data on this, or anybody else also on the panel? Yeah, so this is another topic which has come up in HER2 positive breast cancers, that what is the difference between tumor infiltrating lymphocyte patterns in HER2 positive versus HER2 negative tumors. So it is seen that HER2 positive tumors are more lymphocytically enriched than the triple negative and HER2 negative tumors, and which is why this entire, the study which was presented here involved the HER2 positive breast cancers, because these were the ones which were tumor infiltrated. Possibly there could also be some hypothesis on evaluation of immunotherapy subsequent to HER2 blockade. And continuing the same, Dr. Ashish, if you would like to comment on this, does tumor infiltrating lymphocyte pattern change once the patient is treated? Do you have any thoughts on that?
So I'm not sure about the specific question, but in general, if you look at TILs, we know they're probably prognostic. Like for example, if you have a tumor with a higher TIL infiltration, they do well irrespective of the treatment they receive. And I think if you look at breast cancer in general, we all have only escalated our therapies so far in the past 2 decades, more so for TNBCs and HER2 positives. And if you just look at, for example, a T2N0 TNBC, the poor lady has to receive anthracyclines, taxanes, platinum, immunotherapy, and this may be over-treatment for a lot of our women, correct? So I think the field is moving towards finding a biomarker which can tell you in the beginning, this patient is very likely to have a PAT-CR, and we're probably going to de-escalate. Regarding the HER2 story, the slide you showed, that if you have a higher TILs, maybe you don't need a dual HER2 blockade. And maybe all the benefit comes from bad tumors or the immune desert kind of tumor. So that's where we are. Now, because we are not doing it routinely, I can't answer your question whether how does the pattern change or what is the pattern. But that's something which I think all our pathologists should be made more aware, and we can start looking at it.
So one of these papers which came out actually in 2019, and then there were subsequent 2 other papers which the same group published, it actually showed what you just mentioned, is that the high density of tumor infiltrating lymphocytes is a good prognostic factor. They looked at HER2 positive tumors, and with treatment in these cases, in a certain subset, the TIL concentration was seen to reduce. And that kind of shifted these patients from a potentially treated good outcome to a not so good outcome and resistant. So there is no data of actually change in HER2 expression along with change in TILs in this particular study, but I'm sure these are things that we are going to look at. So yes. 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 So HER2 blocking drugs are classically known to reduce the TIL concentration. You are giving it in a patient with a high TIL concentration, and once you have given after HER2 therapy, the tumor infiltrating lymphocyte concentration is seen to be dropping, and the tumors are less sparsely infiltrated with lymphocytes. So that is the, what this study has shown. However, they have not evaluated in adjunct the HER2 expression.
So HER2 blockade is, I understand that HER2 blockade will have an effect on the TILs. But the other medications, a lot of steroids given along with it, depending on the chemotherapy, I'm sure that will also have some impact. I mean, I'm just wondering.
I think we are talking two different things. I mean, we just spoke about TILs at baseline sample. Now we are moving to TILs at the residual disease.
Correct.
So with the TILs at baseline, and I don't think anyone knows what to do with TILs at the residual disease. Like for example, tomorrow you have a lady with residual TNBC, one with high TILs, one with low TILs. What do you do differently in both of them? We still don't know. We still have to learn.
Right. But what has in the preliminary in this particular paper and its consecutive follow-up, what they have shown is that the TIL concentration reduces, the tumor infiltrating lymphocyte becomes more sparse as the patient is treated with HER2 blocker. That is what has come out. So whether we use that as a prognostic marker, whether we correlate it with HER2 expression, that is still to be seen. So I think we can move on to the last part of the, in the last 2 minutes. So was there any difference in prediction of, and I can actually start with Dr. Chetan Deshmukh, in the prediction benefit of abemaciclib using the whole exome sequencing and the transcriptome provide. Actually, this should be a question for Dr. Anup. No, this study was presented by, you presented this study, sorry. So you are the right person to, between whole exome sequencing and transcriptome profiling, do you see that there was any difference in the predictions? Because they showed the oncotype data as well. So do you see that there was any difference in the prediction of the outcome, or both were overlapping?
Both were overlapping.
Both were overlapping. Okay. Why I wanted to make this point is a lot of labs are coming up with whole exome sequencing or large spectrum exome sequencing along with transcriptome profiling. But in clinical practice, actually, when we are looking at drug response, there is barely any difference because it adds significantly to the cost by doing a transcriptome profiling or an RNA sequencing. Also, the pre-analytical requirements are different. So in this study, that was shown. Also, if we can continue, Dr. Parekh, your thoughts on as the Monarch E had already randomized the patients on high-risk cases, when we look at those pie charts which you showed for the oncotype DX, it further substratified into certain high-risk and low-risk. So was that like a re-stratification which happened?
I think that was the same because the score was like standard oncotype, it is 21. Here they have given that score as 25. So I don't think it was quite different. It was almost...
It was same, but then what it did was the entire monarchy cohort out of which this subpopulation was taken was already stratified.
Yeah.
Now from that, once the stratified population, you add another RNA sequencing assay, which that was, it further segregated it into further high risk and low risk cases.
Yeah.
So the point that I was trying to
I think they are already high risk patients because node positivity and low risk were even not taken in the monarchy trial.
Right. I don't know if we can open your presentation, but I think in the interest of time, we'll just move on. Maybe we can take this offline.
So I think
I mean, over the years, we've tried to see who are the patients who respond better to CDK4/6 in MBC, right? So there's a lot of work done on luminal A, luminal B, high score, low score, and we found that everybody benefits. I think this is the same set of work they're trying to do it in early breast cancer, and no surprise that everybody seems to benefit, or I mean, maybe some more, some less, but these are not the biomarkers we can use to single out women who are high risk just based on the stage.
Right, right. So I think the third point we have already moved on, but just finishing off, considering the top 5 mutations that were presented in this data, the PIK3CA, TP53, CCND1, MYC amplification, and FGFR amplification prevalent in the ABEMA plus endocrine therapy subgroup, does it indicate that this therapeutic combination overrides this, all of these mutations which have different therapeutic options, like the PIK3CA at least and the FGFR1, or is there anything else? Actually, you know, there was a picture in the end for the MYC, so I'm trying to allude to that. Dr. Ashish, Dr. Chetan, please.
So when this study was done, I was one of the PIs for Monarchy. There was no such stratification. It was all comers, all those patients with those pre-specified criteria of high risk. Having said that, if this is, it's always easy and easy to become wise in retrospect. So now if somebody shows me that, well, with PIK3CA, TP53 and CCND1, this combination works better, so be it. But during the study, there was no such, there was not even a talk. The study happened from 2017 and some of the patients are ongoing. No communication was sent to us.
Right. Dr. Anup.
I just wanted your inputs, like the top 5 mutations which have been reported here, there is a bit contrast, like the ATM and other genes which are commonly reported in most of the databases. I am surprised it doesn't figure here.
Were not there, yeah.
That is surprising for
Definitely, yeah. Depending on the depth of the assay, etc. If you see the Monarchy trial, actually this particular study, they have in the end identified that the MYC amplified patients were falling in the poor response subgroup. So that kind of fits into what we already know about the MYC amplification with the other things. But possibly the variable responses which we have seen across the response subgroups also needs to be relooked at least with the PIK3CA and the FGFR1 amplified subgroups. So I think we are done and on time. If we have time, we can take one other point, or you want to move ahead?
It all depends on the audience. Do you all want a break or do you want a discussion?
I have one.
We can continue with the discussion and people can grab their cup of tea and coffee, or we can have a break and end it here. So
No, please. Yeah, I think there's
there
one
is
question.
a question.
Actually, this is question regarding use of CTC or ctDNA in practice. So just question popped in my mind that, so for example, if it is a triple negative on surveillance post-treatment and incidental detection of lung mets, tiny nodules on CT scans, and there is non-biopsyable. So can we use ctDNA CTC in those situations either to monitor or to when to start therapy? Actually, in practice, what we do is, as patient is asymptomatic, we don't start treatment and just we see clinically and do serial CT scans. So in those subset, can we start therapy and can we use CTC or ctDNA in those subsets?
So you're talking of untreated new patients or patients
it
in
is
the
post-treatment.
Post-treatment, yeah. So actually, I was part of 2 large CTC studies which was done. One was for screening in completely asymptomatic individuals, and it is the largest CTC study published. It had 168,000 asymptomatic individuals followed up over a 12-month period of time. And the predictive power of CTC detection, CD45 negative EpCAM pan-CK DAPI positive cells was found to be 100%. 100% of those individuals developed radiological and physical evidence of the tumor on a 12 to 15-month follow-up period. So that showed the power of CTC based on some new technologies. The FDA certified cell search technology does not meet into these sensitivity criteria. The other factor is post-treatment patients, which is your question. So on that also we did a limited subgroup of lung and breast cancer patients, all subtypes included, where again we showed that pre-treated patients who had CTC positive actually had physical evidence of relapse of disease within the next 3 months' time or 1 quarter of follow-up. So it really depends on the clinical judgment whether you want to initiate that treatment or whether you want the patient to have a positive lesion on CT or PET.
So if I can
Your
just...
traditional wisdom would say that you would wait,
No, I can just add to that. So there is a randomized trial was done with pembrolizumab for TNBCs. So all these women who had a positive ctDNA, they were randomized to pembro versus no pembro. This is adjuvant, right? They have no disease on scans. And this is a negative trial. So giving pembro at the detection of ctDNA did not prevent a relapse, right? So now, so there's no doubt these are very good prognostic biomarkers. So as he said, 100% chance or maybe 80% chance, 90% chance. But are they predictive? I don't think so. As of now, we don't have any information. So unless they're predictive, we cannot say whether they're prognostic as well, or they can be used as a surrogate as well.
And your therapy
But Dr. Ashish, one point on that is this was a pembrolizumab study.
Yeah.
So, we are classically evaluating only immunotherapy response.
No, so the point of doing this test is what? I mean, you want to save a life, right?
Right.
The lady is anyway disease-free. You pick up a test and you want to save her. If you're not able to save her, what's the point? Right? So that's what I'm saying.
Your toxicity of treatment has to be justifiable, right? You're going to put her through a toxic therapy for a lady who is asymptomatic based on a ctDNA or a CTC report. Traditional wisdom says that you would probably wait and allow that lady to earn her chemotherapy than push in right now.
No, I think that point is well taken, that if you do an assessment like that, whether you start treatment immediately or not is one thing, but maybe you would want to follow up this patient more closely.
But once you detect something, the patient is going to become extremely jittery. The patient knows that, well, there is something wrong with her report. Now she wants something to be done. We as oncologists know that as of now, we have that information, but we don't have enough science to back our action on it. Am I right? Is that what the panel has also agreed, that right now, based on CTC, we are not in a position to add on any new intervention. And that intervention is potentially toxic.
Well,
So
there
it
are
will be-
two studies that were shown in ESMO this year. One was for neurological tumors, gliomas, high-grade, intermediate to high-grade gliomas, and one was a lung study. In both of them, the chemotherapy intervention actually enhanced the progression-free survival.
So that's for lung, and we are talking about breast. Right now, we don't have any science to back.
Right.
Can I make a point?
Totally agree.
Yeah. What I was telling is that obviously in a curative setting where you have completed your adjuvant treatment, there having CTC as a predictive marker for further treatment, we are not very sure. But what about areas where we are not even clear of continuing treatment or not? Say oligometastatic disease, where you have treated, but it's actually an oligometastatic disease. What is your opinion? Do you think there right now we can start utilizing CTCs as a predictive marker of continuing treatment, or a patient with low volume metastasis which is completely asymptomatic and the mets are stable radiologically stable since last 2 years, 3 years, and do you want to continue treatment, not continue?
So that may be a good suggestion. So here he's saying we are all talking about escalation.
Yeah.
He's talking about de-escalation.
De-escalation.
You've got a lady with oligometastatic disease, incomplete metabolic response on PET. Would you be brave enough to stop therapy if your ctDNA is negative and restart when it rises again? So I think that's how we should be thinking, and how should we make this test useful for the patient, rather than bringing palliative treatment up front when there is no disease.
And in that also, we actually see the power of that prediction, de-escalation increasing when we add a ctDNA with a CTC-based assay together, rather than a single marker. So many of the tumors are variably shedding for the cells as well as for the DNA. So
Actually, in hematological tumors, we have specific mutations but in solid tumor, there are many mutations which are going on.
Right.
So in ctDNA, you as a technical person, I'm asking. So do you target to find out some specific mutations in ctDNAs, or whatever mutations, or you study all the mutations? Because there are a lot of mutations in solid tumors, and it's mutations are evolving over time.
So there are 3 kinds of ctDNA assays which are available for solid tumors. One, like what was shown, is a whole genome or a whole exome sequencing assay, where you are really looking at sequencing the entire genome that you have got after extracting the circulating tumor DNA from the plasma. I think that's where the approach becomes very open. The limited approaches, the 2 types of limited approaches are look at a broad spectrum comprehensive genome profiling, which includes more or less 200 to 1000 genes that are involved in various tumor pathways like the kinase pathway, mTOR-AKT pathway, vascular angiogenic pathway, drug resistance pathway, etc. That is also fairly well set. And then there are very limited panels which are looking at about 20, 25 genes, 50 genes, which are of therapeutic significance. Like in a lung cancer, you can look at EGFR, NRAS, KRAS, BRAF, TP53, ROS, ALK, etc., and track that patient.
Just to add on, like on the tracer trial, the precision oncology customized panels, customized ctDNA assay for every individual. So that's the 4th category. Yep.
Yeah.
Dr. Chirantan, I think we can find up now.
Thank you so much for the extra time. Thank you to the panelists.
May I request everybody to please come together for a group photograph? I think speakers are already here. Chairperson is also there. So Dr. Bose, will you please join them for a picture? Thank you very much. We move on to the next session, which is on HER2-positive early breast cancer. And to chair this session, I would like to call upon Dr. Vaishali Zambre, who is a senior consultant and unit head breast cancer surgeon at RGCIRC Delhi, and Dr. Rajesh Sauji, who is a consultant onco and robotic surgeon at Kamal Nayan Bajaj Hospital, Aurangabad. Before I hand over the session to the chairpersons, my sincere request to the speakers and to the moderator to please stick to the time which is being allotted to you. I would like to call upon the first speaker, Dr. Manish Sharma. Dr. Manish Sharma is a senior consultant medical oncologist at Action Cancer Hospital, Delhi. Over to you, Dr. Manish.
Thank you so much for inviting me. Good morning to all. And this is the abstract presentation, the individual patients of clinical and translational biomarkers for prediction of pathological complete response after de-escalation therapy in HER2-positive breast cancer in 4 trials of West German study group, that is WSG group. So coming on to the background, in HER2-positive early breast cancer, establishing a safe therapy de-escalation strategy to avoid systemic chemotherapy associated toxicity requires a precise patient selection. So they set out to determine the predictors of efficacy and survival in the unique setting of 4 WSG de-escalation trial, where the total number of patients was 756, evaluating a short course of neoadjuvant treatment with or without chemotherapy in HER2-positive breast cancer. So they investigated the prediction of PCR by clinical and translational markers with the potential to identify the patients with favorable prognosis after systemic chemotherapy therapy-free neoadjuvant treatment. So methods, BC360 gene expression data was available for 413 patients, and further 146 patients in ADAPT hormone receptor positive trial, and gene and signatures were reconstructed from custom 800 gene panel by linear regression. A logistic regression model was constructed for PCR for each gene signature and stromal tills, adjusted for clinical tumor size, node, hormone status therapy, and the use of TDM1 or pertuzumab plus trastuzumab plus minus endocrine therapy, and including both average signature associations with PCR and predictive interactions. The prognostic score for PCR was developed by the gene signature in the pre-specified single gene therapy, and then there was an independent validation cohort in which the score was validated. So this is the overview of the 4 WSG de-escalation trial in HER2 positive early breast cancer. First is ADAPT hormone receptor negative HER2 positive breast cancer, where the patients, they were given pertuzumab plus trastuzumab versus short course of chemotherapy, pertuzumab plus trastuzumab plus paclitaxel. And you can see the PCR rates were higher, approximately 90% in those patients who received chemotherapy, while it was 34% in those patients who received P+3 treatment. And the 5-year IDFS was 87% versus 98%. Similarly, the other trials were KEYRICH-1 trial, which included HER2 positive patients, both hormone receptor positive and negative. Patients here were receiving pembrolizumab plus trastuzumab plus trastuzumab biosimilar. The other trial was ADAPT hormone receptor positive trial. The patient here received TDM1 or TDM1 plus endocrine therapy, or TDM1 or trastuzumab plus endocrine therapy. The other trial was TP2 trial. So all of these trials, this is the overview of all these trials which were included. And the association of the biomarker with PCR, this is for the patients without systemic chemotherapy. So PCR after systemic chemotherapy-free neoadjuvant treatment is associated with TDM1 and dual HER2 blockade plus minus endocrine therapy, higher levels of ERB2 expression, immune-related gene signatures, and stromal tills dependent on the TDM1 use or the use of dual HER2 blockade plus minus endocrine therapy. And ESR1 and PGR signatures are surrogate for hormone receptor status. So this was validated in another trial, another validation set. And you can see on the right hand side there is the prognostic score for PCR after systemic chemotherapy free treatment. And the prognostic score included the genes like ERB2, MYC, gene signature, IDO1, and clinical characteristic. In the high prognostic score group, that is 50% of the tumor, PCR rate was around 60% in the chemotherapy-free treatment. So coming on to the conclusions, the data from the 4 unique WSG de-escalation trial in HER2 positive early breast cancer indicate that the use of TDM1 or pertuzumab plus trastuzumab plus minus endocrine therapy induces substantial PCR rates even without systemic chemotherapy, and there is strong impact of ERB2 signature even in the cohort including 90% of the HER2 IHC 3 plus tumor. If HER2 3 plus is included, ERB2 still contributes to the prognostic accuracy of PCR. The activation of immune response mechanism is associated with PCR after systemic therapy free NAT. And the score developed in the systemic chemotherapy-free cohort identifies a group of patients with 60% PCR rate. And the further studies, they are being done with the third generation ADCs like TDXT. Thank you so much.
Thank you, Dr. Manish Sharma. I now call upon Dr. Vivek Agarwala. Dr. Vivek is a director in the Department of Surgical Oncology at Narayana Health, Howrah, Kolkata.
Good morning, everyone, and thank you, MOC, for having me here. And I am a medical oncologist at Narayana Health. And the abstract I am presenting is event-free survival by residual cancer burden and intratumoral HER2 heterogeneity after neoadjuvant TDM1 and pertuzumab for early stage HER2 positive breast cancer. This was presented by Otto Metzger. So before I delve into the data, let us understand 3 terms. One is RCB, residual cancer burden. So as opposed to PathCR, which is like a dichotomous variable, RCB is like a continuous score from 0 to 3 to assess the post-neoadjuvant therapy pathological response, with a score 0 is path CR, and a score 3 is like no pathological response with no decrease in cellularity. And what is seen is if there is a major pathological response with a RCB score of 1, these patients, they do as well as patients who have a complete pathological response, so that the RCB low group with 0 to 1 score doing good and RCB high group with a score of 2 to 3 doing bad. Second is the concept of HER2 ITH, HER2 intratumoral heterogeneity. So this is a concept that is evolving since last few years, where 40% of patients who have HER2 positive disease are seen to have intratumoral heterogeneity, which causes HER2 resistance. This is not in terms of ERPR positive or ERPR negative, but even in HER2, we know HER2 positive can be from 10% cells to 100% cells positive on IHC, or there can be higher HER2 copies, or there can be higher HER2 by CEP17 ratio. And now with AI tools, you have a lot of applications to detect intratumoral heterogeneity, which is of different types, genetic, non-genetic, and further classified into different presentations. And third is the HER2 diagnostic scores. So as opposed to the traditional FISH positive or IHC positive, now we have higher HER2 diagnostic scores like HER2-DX or the ERB-B2 mRNA scoring. So what is HER2-DX score is this takes into account not only the clinical and pathological factors, but also the luminal characteristics, the tumor infiltrating lymphocytes, as well as your gene signatures related to HER2, including 27 gene expression analysis, making it a score where a higher DX score means more sensitive to anti-HER2 treatment and a lower score means more resistance. So with this, let us look at this study where what they did was, selected 163 patients, did baseline biopsies to assess heterogeneity, and then gave them neoadjuvant 6 cycles of TDM1 plus pertuzumab, and then a surgery was done to assess path response, as well as further routine treatment and then assessment of EFS. And what we see is that patients who had intratumoral heterogeneity has a 0 path CR as compared to patients who did not have heterogeneity, where the path response was nearly 55%. If you look at the RCB score, here also the RCB 0 to 1 is significantly less in patients who had intratumoral heterogeneity. If you look at EFS with this regime, 91% 5-year EFS, but again patients who had intratumoral heterogeneity, the EFS was 81% as compared to 92.5% if there was no heterogeneity. And patients who required adjuvant treatment had a 90% 5-year EFS as compared to patients who had a complete path response, did not require any further adjuvant treatment. Again, HER2-DX score, it shows that path CR rates were higher if you have a higher HER2-DX score or if you have a higher ERB-B2 mRNA score. So the conclusions of this study was the inferior path CR rates among cases classified as ITH HER2 positive were translated into a worse survival outcomes. Neoadjuvant TDM1 and pertuzumab represents an optimal regimen for patients without any intratumoral heterogeneity, and response defined by RCB could be used to select patients for a chemotherapy-free regimen in a prospective clinical trial. And HER2 level measured by either a single cell FISH analysis or a ERB-B2 mRNA is a strong predictor of response to neoadjuvant TDM1 plus pertuzumab. Now these scores, they become really relevant currently when we have so many anti-HER2 treatment options available, especially with N-HER2 coming in, which has a higher bystander effect, a higher payload. So probably using RCB and these HER2 scores as well as the HER2 ITH, we can tailor our treatment as to which anti-HER2 treatment may be suitable for our patients in the curative setting. Thank you.
Thank you very much, Dr. Vivek Agarwala. I now invite Dr. Mansi Khanderia, and she's a medical oncologist leading the department at Sparsh Group of Hospitals in Bangalore.
Good morning, everybody. So I think after that dynamic talk, I'm going to talk something very simple, which we all know about. So this was a retrospective analysis of the National Cancer Database on elderly patients with early breast cancer, HER2 positive. Early breast cancer in this particular study consisted of stage 1, stage 2 as well as stage 3 breast cancers. So we know that breast cancer incidence increases with age, and patients over 65 years old, which we count as elderly, account for almost half of breast cancer related mortality, at least in the Western world. Here we are seeing more and more younger patients as well, and we know that about 15% of breast cancers are HER2 positive. Now the standard treatment includes chemotherapy with MAB, either just trastuzumab or also with pertuzumab in all the patients. But in geriatric patients, we do see that there is significant toxicity, and some of us are not very comfortable with chemotherapy. So the objective of this analysis was to compare the survival of geriatric patients with chemo plus MAB versus MAB alone, or no treatment, no systemic treatment at all. Of course, if they were hormone receptor positive, ET was allowed. So the retrospective analysis was conducted for over 10,000 patients, and the main objective was to assess the all-cause mortality. It was not specific breast cancer related mortality, but all-cause mortality. And after adjustment of for multiple variables, they did want to analyze using the log P rank value, the age cutoff after which survival may vary between the treatment groups. So if you see the demographics, almost 9,900 plus patients, so 10,000 patients were analyzed. 30% of them did not receive any treatment, 70% received treatment, out of which about 92% received chemotherapy plus MAB, and about 7% received only MABs. Now, they were not well matched, of course, because this is a retrospective analysis, but there was representation from all the races, age, you can also see the nodal status, also the comorbidity index was also analyzed in this. These curves are so soothing for all of us to see, with more and more trials having less and less gap between the two curves, but this is KM curves of CT plus MAB versus MAB alone in the first graph, and the second one is CT plus MAB plus no treatment, with no treatment at all. So if you see in the first year, the survival difference was just about 3% between chemotherapy plus MAB versus MAB alone. However, when you see in the 3-year survival, just between these two arms itself, you see a difference of about 14 to 15% at 3 years. And when you compare it with no treatment at all, so CT plus MAB versus no treatment at all, of course the difference is much higher. It's 15% plus, 77% versus 92.9, so 93%. So it's about 16% of difference if you don't give them any systemic treatment versus giving them a complete CT plus MAB at 3 years. So the Cox regression survival analysis also did favor CT plus MAB, obviously. Conclusions were that chemotherapy in combination with HER2 therapy demonstrated a significant survival benefit in geriatric patients. They did a age year-by-year analysis of log rank p-value, and at any age the cutoff was not in favor of not giving CT plus MAB, which was very important. So right from 65 till 90 years of age, there was a benefit of CT plus MAB even in elderly patients. So this data highlights the importance of individualizing treatment recommendations and not foregoing standard therapy based merely on age. Of course, this is retrospective data, but we also have a phase 2 randomized study from the Japanese group, which also proved this. So we are not doing a favor to the patients by sparing them from chemo if they are elderly. We should obviously see what can be tolerated and not tolerated. We have many anthracycline sparing regimens, and even if you think docetaxel or carboplatin are not good enough, at least paclitaxel plus MAB should be offered to elderly patients until and unless they are not good functionally. If the functional status is not good, irrespective of age, we would not offer. So, and definitely we need biomarkers to help guide escalation and de-escalation, which has been a topic of debate for years now for early stage HER2 breast cancer. Thank you.
Thank you, Dr. Mansi Khanderia. I now call upon Dr. Akshay Shivchand for the next presentation. Dr. Akshay is a consultant medical oncologist at MOC Kolhapur.
So good morning. I think again this task has given to me, and there is something like if you come across sub-analysis of any great trial, so we are very eager to know about what is the extra thing that the investigator want to give us. So this is the benefit of adjuvant pertuzumab and trastuzumab according to estrogen receptor and HER2 expression, and it is a sub-analysis of the affinity trial. Now, this was presented by Elisa. So the background and method, as we know, this was affinity trial, was randomized double-blind phase 3 trials comparing the addition of pertuzumab or placebo to adjuvant trastuzumab chemotherapy in patients with HER2 positive early breast cancers. Now, in the present exploratory analysis, they have tried to investigate the magnitude of benefit from the addition of pertuzumab to trastuzumab and chemotherapy according to hormone receptor and HER2 expression levels. What they did was the HER2 FISH amplification ratio was categorized as low. So the FISH ratio, if it is less than or equal to 2 and below 5, so they are categorized into HER2 expression as a low, HER2 FISH amplification low, and as against FISH ratio, if more than or equal to 5, they considered it as it's a high. So ER expression on IHC was categorized as negative versus positive using 1% and 10% as cutoffs. And a subgroup analysis using Cox proportional hazard regression models was used to model the invasive disease-free survival, assessing 4 categories formed by the cross-classifying the FISH ratio and estrogen receptor groups. So if you look at the results, so 4782 patients were included in this analysis, and the IDFS benefit from the addition of pertuzumab was consistent across ER status and FISH ratio subgroups. So overall population, if you see the this forest plot, these all are benefited by adding pertuzumab, but if you see the FISH low and ER positive patients where the graphs are not crossing unity and they have got the maximal effect as against the patients who are FISH high and ER positive or FISH high ER negative, the line is crossing the unity. So what they conclude further, I think this connect to all the souls yesterday night were dancing here. So in this affinity sub-analysis, all patients treated with pertuzumab and trastuzumab derive similar IDFS benefit regardless of estrogen receptor and HER2 expression. The HER2 FISH ratio low ER positive subgroup had the largest reduction in the risk of an IDFS event, that is 30% for the pertuzumab arm versus placebo. So the subgroup of tumors with HER2 FISH ratio high ER negative expression showed the numerically smallest benefit in IDFS even with the addition of pertuzumab. So what they conclude that tumors with high ER to FISH ratio, now here high ER to FISH ratio is FISH ratio more than or equal to 5, could be more HER2 addicted and derive a greater benefit from only single HER2 blockade, with a relatively lower benefit from addition of second HER2 blocker agent, that is pertuzumab. On the other hand, the tumors with low HER2 FISH ratio may be less HER2 sensitive and they derive a relatively higher benefit from the addition of dual HER2 blocker. So the last line says all considerations are exploratory and hypothesis generating only. Thank you.
Thank you very much, Dr. Akshay Shivchand. We now have a case-based panel discussion. And as moderator, I would like to call upon Dr. B.K. Smriti ma'am. Ma'am is a senior consultant medical oncologist at Leelavati Hospital, Mumbai. I will quickly call upon the panelists as well. Dr. Prakash Devde, who is a consultant medical oncologist from Aurangabad. Dr. Preetam Kalaskar, consultant medical oncologist from Thane. Dr. Ashish Singh, senior medical oncologist from CMC Vellore. Dr. Jayesh Kori, the consultant oncosurgeon from Thane. Dr. Neerja Gupta, the breast surgical oncologist and oncoplastic surgeon practicing in Delhi and NCR. Dr. Sanjay Dudhat, who is the senior surgical oncologist. Dr. Bhavin Visaria, senior radiation oncologist from Mumbai, currently working with HCG cancer centers at Borivali and Kolaba. And Dr. Debanshu Bhadri, who is a senior consultant in surgical oncology at M.N. Budrani Cancer Institute. Ma'am, you have 25 minutes.
Yeah.
Thank you very much.
Yeah, so I'd like to thank the MOC for giving me this opportunity to moderate this panel. You can just move on to this. So this is I would start with the case. As I said, there's been nothing path-breaking in HER2-positive early breast cancer, but there is a little bit of fine-tuning, and I think we can do that with the help of this case. The 52-year-old post-menopausal right breast lump 3.5 centimeters, node negative, ER positive, HER2 positive +3, early breast cancer. Now, I would like to begin with the surgeons and find out, would you do a primary surgery here, or you'd refer the patient for, the systemic therapy first? So can we begin from the end? Because all the surgeons, I requested them to sit at the end.
I think the tumor size is 3.5. It is not very early T2. I think we should go for neoadjuvant rather than the surgery later on. Not a primary surgery.
Can you just speak into the mic? It's echoing. I couldn't hear your response.
Tumor size is 3.5 T2. It is not a very early T2. So it is, though it is node negative, I think, of course, it is a debatable with surgery and chemotherapy, but I would go for neoadjuvant rather than surgery first.
You next? Yeah.
Same, NAST first.
Yeah.
Neoadjuvant.
Yeah.
Ma'am, I will go for a surgery based on what the patient wants. So the breast size is better, large breast size. Then I prefer for a breast conservation, if the possible, for that. I will go for a first surgery. If I say small breast size for even 3.5 and needing a mastectomy, then I will go for a NACT and then will go for surgery.
Dr. Neeraj?
Yeah. Ma'am, I would actually give the choice to the patient, I think both options are on the table. Surgery up front or NACT up front in this case.
The second from that side.
Yeah, so surgery first is not contraindicated, but the fact is, as we see, post-NAST is indicated because we want to prognosticate the disease. The response to the therapy would be a clinical marker for us to understand the behavior of the disease in future. So that would just be a clinical guideline. Otherwise, if the patient insists, the patient choice is the first thing. If the patient insists for surgery, definitely it's not a contraindication.
So I would now like to ask the medical oncologist, what is your view on this patient? Would you like the patient to come to you first or the surgery first? So quickly, because we have only 25 minutes. Yeah.
So this tumor is T size more than 2 centimeters, even if it is node negative. I'll go for neoadjuvant. Definitely, if it is a dual HER2 blocker, if she is affording. But even if HER2 is not there, I'll go for NSCT first.
Yeah. Any of the other medical oncologists?
I agree with anything more than 3 centimeter NSCT first.
How about you?
I'm a radiation oncologist.
Oh, sorry. Yeah. So, now there is a divide that, the surgeons feel that if they can do a breast conservation, they would like to go for that. And the medical oncologists feel that they should first give neoadjuvant therapy. Well, at least in the guidelines, it's recommended that any tumor more than 2 centimeters in size or node positive should actually receive neoadjuvant therapy. It actually helps in personalizing the post-surgical options for the patient, so you can recalibrate your adjuvant therapy depending on what is the response to the neoadjuvant therapy.
Ma'am, it's node negative. I think
So
it's,
even if it, but it's more than 2
I would
centimeters.
counter a bit, even if it is a node negative thing with a 3.5 centimeter tumor and the patient doesn't respond, if you have a low PCR, if the patient doesn't have a good PCR, there is data to suggest that even the nodes can be positive. There is a study by Mayo, 500 patients, and they found out with the tumors, it was CN0 they started with, they gave NAST, but at the end of the day, the patients who did not respond, they had 16% of the patients having node positivity. So node negativity is not a single direct criteria to suggest that it will land up as a node negative situation later
So
on.
that's what I said, that either tumors more than 2 centimeters in size or node positive. So these are the patients who should ideally receive neoadjuvant, though I know in practice it's quite different. You wanted to say something?
Yeah, so also on imaging wise, defining a node negativity is not always, there is a discordance when you go for a upfront surgery and you many a times find a lot of node positivity.
Yeah. So, of course, as I said, most important is individualizing therapy post-surgical, depending on the residual disease. So that is the reason. So what are the criteria? So starting from the medical oncologists, I mean, what are the criteria for NACT in HER2 positive disease? All patients, or you have already mentioned that, so I don't think we need to go into that. So are there any markers today which can predict for a pathologic complete response? Even though you're a radiation oncologist, you could very well contribute. So there's no issue. You could answer that. Yeah.
So molecular markers for PCR?
Yeah.
So molecular markers for PCR?
Clinico-pathological or molecular, like.
So like ER negativity is strong ER negativity, high on HER2. Even on, there was a presentation of high FISH expression of HER2. These are some, like if your tumor is only driven by HER2, there is a high chance of getting a PCR rather than hormone receptor also driving it. Or maybe negativity on other receptors like PIK3 and other things can also drive the tumor biology.
So, yeah, please, if anyone has anything more to add.
Therapy point of view, if it is a dual target, dual blockade, it's more chances of paths here than single.
Yeah, so the other thing is, I want to know from you all, anyone can take that question, that how often do your pathologists really actually report on intratumoral heterogeneity as far as HER2 positive is concerned, the TILs? I just want to know that.
Never.
Anybody? I don't think our pathologists are reporting on that, though actually it's a simpler way. It's one of the important prognostic factors for a PCR in this situation. So I think one can go back. Anybody in the audience wants to say that any of their pathologists report on these 2-3 factors which are, simple but important?
Unless you tell the pathologist specifically, then only they will report. Otherwise, in the routine report, they will not mention.
Yeah. So that is the thing. So I think these are the markers for PCR. But tell me, I want to ask the medical oncologist, would you use any of these to decide whether you want to give neoadjuvant therapy or not?
At present, for a young 52 years old, I may not use in practice. But yes, definitely, if there is somebody with a comorbidity and where I feel chemotherapy can be dicey, definitely these markers can guide me for defining.
So basically, I just want to say that at the moment, there are no markers, whether they be molecular or pathological, which would help you to decide that, okay, this patient is going to have a PCR, so I would go ahead and give NACT, or this patient won't get a PCR, so I will not give NACT. So these factors do not help you to decide at the moment. And then what regime do you use in NACT therapy? Single, dual, anti-HER2 blockade, the medical oncologist?
Yeah, so dual anti-HER2 blockade.
Yeah,
with
all patients who need NACT?
All patients. For a 3.5 centimeter, yes. Dual HER2 blockade with taxane, TCHP regime.
Would like to say?
At this point of time, dual anti-HER2 blockade, and if the other ITH and all, if it is standardized, then you may de-escalate to a single this one.
Yeah, anybody else wants to add anything?
So I think we've been discussing on dual versus single. I would like to ask the medical oncologists. We had a presentation today afternoon also.
Can
So
you just
do
speak
the
slowly, please,
yeah.
because it's
So
echoing.
for single versus dual, would your TILs decide on this giving a dual versus single blockade? I think we did have a study on this, right?
So presently, I don't think it has been reported. You are talking about TILs, I think so.
So you go for a dual blockade for all the patients?
Yeah, most of them.
Anybody in the audience can participate, please. So you're welcome to do that. So do you use chemotherapy-free NACT in any patients at any time in HER2 positive patients? Do you use, last question, do you use chemotherapy-free neoadjuvant therapy in HER2 positive early breast cancer? Medical oncologist.
No, madam.
Yeah.
May I request the people at the back of the hall to carry out the conversations outside the hall because it is reaching till here. Thank you very much.
Okay. So, one last question. So, today, as of now, which regimes are you using in the neoadjuvant therapy? Can you just tell me? Anybody?
TCHP.
TCH, yes.
TCHP, TCH.
TCHP, TCH, yes.
Or in some cases where we see high nodal burden, anthracyclines, and then followed by T plus H.
Yeah. So, there is not much scope for de-escalation. So, I think, you wanted to say something? Yeah. So, I think as far as neoadjuvant therapy is concerned, de-escalation means basically first looking at dropping the chemotherapy part. And I think at the moment we are not having robust data to do so. So almost everybody you could see from the last paper, even in the elderly population, adding chemotherapy in these patients does help. Now, do you use de-escalation strategies in the adjuvant setting? Which are the ones anyone can take?
No, not at present.
In the adjuvant setting? In the adjuvant,
yeah, in adjuvant setting, definitely nothing as such of de-escalation at present, but addition of pertuzumab is slightly controversial where to add it. So maybe the presentation of high HER2 rich can guide on that. Sometimes people are not able to shell out that much, but otherwise the regime remains same.
What about addition of anthracyclines? Yeah. So that is a de-escalation if you don't add anthra. So that is one of the de-escalation strategies. Anything else about duration? Anybody going for shorter duration? 6 months versus 1 year? That is also de-escalation in the adjuvant setting. Anybody can take the question. Yeah.
So high nodal burden anthracyclines is what I tend to prefer in 3 nodes. Otherwise, and on the duration part, presently 12 months only. Wherever there is a cost constraint, then there is an option of 6 months, which is non-inferior.
Okay.
I just want to add one thing. This is my observation. Sometimes de-escalation happens not by choice, but by default because patient does not have money. So those kind of patients that we have seen, that is.
Yeah. And somebody develops a cardiotoxicity, you end it at 6 months. So, at that, so that is one of the, but these de-escalation strategies, yes, please.
I have a question regarding the NSCT setting. Once a decision is made in the MDT that will be initiating NSCT with maybe a single or dual HER2 blockage, whatever chemotherapy, maybe TCH or with paclitaxel, during the sequential cycles, maybe if TCHP are going to do 6 cycles, do you all in your practice do a PET scan or a mammogram to assess the sequential response during the treatment?
Anybody?
To decide if the patient is responding or not responding, apart from the clinical breast examination, to decide if the patient is responsive. And so maybe intensify the treatment, maybe if patient was just on a Trasto paclitaxel type regimen, if not much of a response, you might add a pertuzumab, or if the patient just on a TCH who had not a very good response, do a pertuzumab addition to the regimen.
This is on therapy? While
On therapy, yes, on therapy.
No, we don't. As a unit, we don't do that.
Anybody
Can
else
I,
wants
can I
to
make
take-
a quick comment here? So guidelines are there to just do physical examination before each cycle. We have to thoroughly examine the axilla before each chemotherapeutic cycle. And if there are clinical signs of progression, then we should go for any imaging like PET scan or ultrasound or anything. If it shows progression, then it is on treatment progression. Then we can modify the treatment in that scenario.
So anybody else wants to say anything, then I would.
So imaging as such, PET scan is at the end of therapy, but definitely as Dr. Mangesh mentioned, if there is a clinical signs of progression, then you can do an interim PET.
See, the guidelines do not say that we should be using PET scans to assess treatment while on, assess the response while on treatment. But clinical examination, as mentioned, is very important. Secondly, mammography or ultrasound to know what is happening to the primary tumor. And you should always collaborate with the surgeon. It's not that you keep assessing as a medical oncologist. The surgeon should also be involved in the assessment. And suppose there is a progression of disease, then either you would have to change the line of treatment. Whether to add pertuzumab in between if the patient is only on trastuzumab, it's difficult to say because after all pertuzumab has to come on the piggyback on trastuzumab. So if the patient is resistant to trastuzumab regime, whether addition of pertuzumab would help, I think here in this situation, it should be either TDM1 or a TDXD, not just addition of pertuzumab. So, these are the de-escalation strategies that are established in the adjuvant setting. And of course, the APT and ATTEMPT trial saying that paclitaxel de-escalation to paclitaxel with trastuzumab. So now, coming to the other abstracts, we have already said, will you use any of the prognostic markers mentioned in the two abstracts to actually decide on whether you want to give NACT or not? Anybody? Like intratumoral heterogeneity, HER2 levels?
Presently not using, but yes, once available, this will definitely guide, but not presently using.
Yeah, so they are not really useful for prime time use. As was already shown that in those patients with intratumoral heterogeneity had inferior survival as compared to those who didn't have the heterogeneity. And that is what is important is that PCR is inferior in intratumoral heterogeneity and dual blockade could be ideal for non-heterogeneous patients. These are just suggestions from this. You cannot apply them in the clinic. And that HER2 level measurement by single fish analysis or the messenger RNA could also predict for response to dual therapy. So I think these are, just what is the outcome from this study, but we cannot apply it in the clinic. And also the Greaser study. Now, here it says that, if you give TCHP, okay, tell me what are the, in HER2 positive, hormone receptor positive, what is the type of response you would expect in those patients, PATH-CR? Any of the medical oncologists?
So if it is strong ER positive, then the responses are somewhere around 50% of the patients will get a PATH-CR. But if it is ER negative, then you see a more of...
Maybe 70-80% also. Yeah.
Better.
Yeah. So what I'm getting at is, what has been discussed during that session was, when you use dual HER2 blockade alone with chemotherapy in ER positive hormone and HER2 positive, there also in the WSG trials, you got a PATH-CR of 50 to 60%. And with the whole chemotherapy added on, which I mentioned, you said, is also 50 to 60%. So maybe these are the patients who are PR strongly positive and also they are HER2 positive. So in that WSG trial, they use endocrine therapy along with the dual blockade. So maybe in future trials, these are the patients where you could de-escalate giving up chemotherapy, giving a dual blockade and using endocrine therapy. But I don't think this is actually really good now for prime time use. So this is just in future, this population could be looked at, because by addition of chemo to the dual blockade, you're getting the same patch CR rates as with addition of endocrine therapy to the dual blockade in the WSG trials. So the NCCN guidelines has clearly shown that these are the, all the regimes used in neoadjuvant therapy. And as you can see, nowhere have they mentioned dropping the chemotherapy. So I think that's a clear indication that it's not actually ready for prime time use. Now the use of dual blockade in the adjuvant setting. Now I'm referring to the next study, which was the affinity study. So I want to know that, even the surgeons can answer this, that which are the patients where you use dual blockade in the adjuvant setting. Is it decided by nodal status, hormone receptor status, or the FISH ratio?
It will be better with a nodal status and FISH ratio. So dual blockage will be more with the nodes are positive. So they will have a better outcome.
Yeah. So anybody wants to add to that? So at the moment, for using dual blockade and even the 8.4 years follow-up on the affinity study has shown that the benefit is mainly driven by the nodal status and not by any other features. So at the moment, adjuvant dual blockade one would use by the nodal status. So the benefit of adjuvant pertuzumab and trastuzumab, this was the subgroup analysis carried out in this paper, which was presented as SABCS, that will the estrogen receptor and HER2 expression sub-analysis actually help in this situation. So what was the outcome? Any of the medical oncologists, because you heard the presentation of that paper. So did it differ according to the HER2 expression or the estrogen receptor?
Yes. So if at all the tumor is only driven by HER2 expression and it is ER negative, then there is a definite benefit of adding pertuzumab. That is what is the crux I got of it.
Yeah,
or if it is driven by both HER2 as well as hormone, then you have to add something. If it is only driven by HER2, then trastuzumab is sufficient.
So actually, I mean, I don't know whether it's visible. If you look at the FISH high and ER negative patients, then there the benefit of just the trastuzumab is so much that, addition of the pertuzumab doesn't help so much. But if you look at those who are FISH low or those who are ER positive, they seem to be actually benefiting from this. But remember, this is a very small subgroup analysis. So I don't think, so my question to you is, if a patient is node positive, will these two criteria actually drive your decisions, or the node positive would prevail over this?
Definitely node positivity will.
Yeah, anybody in the audience?
Hello. So just I wanted to make a point. Suppose on Monday morning, just the trial is showing that they have categorized FISH criteria. As we all know, FISH more than 2 in IHC 2+, it is considered to be FISH positive. Though the overall population, trial population has taken an advantage of adding pertuzumab, but they looked at the IHC 3+ with FISH more than 5. So what they wanted to tell is, if FISH is more than 5, so it's better to add only 1. As you rightly said, the nodal status supersedes over whatever FISH. So even in affinity, the benefit of pertuzumab based on only nodal status. So those who have high nodal burden, they will get benefit of pertuzumab. But looking at the cost constraint in our setup, so we can choose our patient according to the FISH ratio, what I feel.
Yeah, but here the presenter clearly stated the numbers are too small to really comment
Yes, ma'am.
and
Yes.
make use this to decide whether the patient needs a dual blockade or not, and whether it can, they never looked at whether it could override nodal status.
yes.
So I wouldn't advocate the use of this. Anybody else wants to differ? And now coming to the last, age as a criteria for offering standard therapy. So again, I'd ask the surgeons, what is their approach to patients and also the radiotherapist? Quickly, because we have only 1 minute.
So I agree that you would want to look at chronological age, you would like to look at physiological age. But when we look at mortality as the only endpoint, we also have to see the kind of quality of life deterioration if you hit them with everything and you go in all guns blazing. And over a period of time, we have found that that doesn't work out too well.
Age is just a number, so we don't consider age. We go by the performance status. If the patient is well performing, good performance, definitely the standard treatment.
So, so yes.
Yeah. So what she has said, the age is just a number, performance status is good. Then you offer radiation also as a part of local treatment, but then we do a de-escalation in radiation. Rather than giving a radiation for 4-5 weeks, we give it, finish it in 1 week. We don't use boost. And yes, there are studies, there are small studies, there are case series which has said that for someone who is more than 70 years of age group and with a not so good performance status, you can omit radiation also, irrespective whether patient is a locally advanced or not, because then in that scenario, the chances of patient having complication or disease recurrence in the systemic setting is higher than the local settings.
So basically, the driver messages don't go by the chronological age, individualize according to other factors. So the takeaway messages, this is the last slide, prognostic factors cannot be used to de-escalate a neoadjuvant chemotherapy in early HER2 positive breast cancer. Adjuvant trastuzumab plus pertuzumab beneficial in node positive irrespective of hormone receptor expression or the FISH ratio. And anti-HER2 therapy and chemotherapy benefit geriatric patients, and treatment needs to be personalized or individualized. So I think with that, I'd like to thank the panelists and the audience for their participation.
Thank you, Dr. Smriti. May I request all the panelists and Dr. Smriti to please stay on the stage as we are having a group photograph. May I request the chairperson also to please come up on stage. And I invite the speakers, Dr. Manish Sharma, Dr. Vivek Agarwala, Dr. Mansi Khanderia and Dr. Akshay Shivchand also to join. Before that, ma'am, would you like to conclude something, Dr. Vaishali? Will you? Yeah, ma'am has done. So we'll have a. Thank you very much. We move on to the next session, which is HER2 metastatic breast cancer. And as chairpersons, I would like to call upon Dr. Ashish Joshi, who's a consultant medical oncologist from Vilepale in Borivali, Dr. Mangesh Mekha, who is a consultant medical oncologist, MOC, Pune, as the first speaker, I would like to call upon Dr. Lavin Wilson. Dr. Wilson is a consultant medical oncologist at SMBT Cancer Institute, Nashik.
Good afternoon, everyone. I'd like to thank the organizers and the chairpersons for this opportunity. The abstract given to me is HER2 CLIMB-02. It is a primary analysis of a randomized double-blind phase 3 trial of tucatinib and trastuzumab emtansine, that is TDM1, for previously treated HER2-positive metastatic breast cancer. The trial was presented by Dr. Sarah Hurwitz. The background for the study was HER2-positive disease, especially those that progress after the first line, and having especially brain metastasis, have a very poor prognosis. And treatment options for those are very limited and don't give much benefit. And also based on the HER2 climb study that showed that tucatinib to trastuzumab and capecitabine gives a significant PFS and OS benefit. This trial was based on to see whether other options of adding tucatinib to other treatment options, will it give any additional benefit. So this was the study trial design. HER2 positive, locally advanced, unresectable and metastatic breast cancer patients with progression after trastuzumab and taxane were involved in the study. Previously treated patients having brain mets were also included. About 463 patients were enrolled, and they were divided into, randomized into TDM1 plus tucatinib, compared to TDM1 plus placebo. The primary endpoint was PFS by investigator assessment, and the secondary endpoints were OS, PFS in patients with brain mets, and objective response, and OS in patients with brain mets. Coming to the demographic characteristics of the two groups, they were similarly comparable. Point to be noted over here is that about 45% of patients had brain mets in both arms, of which about 20 to 25 patients had active brain metastasis, and about 45% of patients had progressed in metastatic setting after one line of treatment. Coming to prior systemic therapies received, most of them had progressed after first line of treatment, and about 90% of patients in both arms had received pertuzumab treatment. And the PFS survival curve showed a 2-month benefit that was 9.5 months for the TDM1 plus tucatinib arm compared to 7.4 months in TDM1 plus placebo arm. The hazard ratio was 0.76 and was significant. The PFS was beneficial across all pre-specified subgroups, much more in those having active brain metastases, which was again showed by the secondary endpoint, that was PFS in patients with brain mets, which was 7.8 months in TDM1 plus tucatinib arm compared to 5.7 months in TDM1 plus placebo arm. The confirmed objective response rate was 42% in the combination arm compared to the 36.1% in TDM plus placebo arm. After the progression, most of the patients went to subsequent systemic therapies, of which most of them received either TDXD or chemotherapy. The overall survival at median follow-up of 24.4 months, as per the author, was quite immature to comment on at this point, and the interim OS results did not meet the pre-specified crossing boundary of p-value less than 0.0041. Coming to safety, the authors commented that most of the in the combination arm, most of the side effects were liver enzyme elevation and diarrhea, and most of were reversible and after stopping the treatment, and discontinuation due to tucatinib was about 17% in the combination arm, and TDM1 discontinuation of TDM1 was almost double in the combination arm compared to with the placebo. So as I said earlier, most of the side effects were significant grade 3 side effects were enzyme elevations, AST and ALT, and also diarrhea. Adverse events, most of the adverse events stopped after, were reversed after stopping the treatment. Conclusion, adding tucatinib to TDM1 significantly improved PFS in patients previously treated with HER2 positive breast cancers. Median PFS was 2 months survival benefit, and OS data was immature. Adverse events were mainly reversible after discontinuation and were mainly hepatic enzyme elevation. So in plain language, the summary of the study was more research is needed for in this setting, especially in HER2 positive breast cancer patients who have progressed and have brain metastasis. Tucatinib along with TDM1 can also be an option as a combination treatment in this setting. The limitations of the study is that the OS data is still immature, but the graph shows that not much expectation is there that there will be an OS benefit. The other thing is it is not compared with other established options like the HER2 climb option of tucatinib plus trastuzumab plus capecitabine or TDXD. Thank you.
Thank you very much, Dr. Wilson. I now invite our next speaker, Dr. Nitin Bias, who is a consultant medical oncologist from Borivali and Malad.
Thank you for the opportunity. So I'll be talking about impact of HER2 expression dynamics on the real-world activity of trastuzumab deruxtecan for advanced breast cancer. So as we all know, TDXD is the standard treatment for patients with HER2 positive and HER2 low metastatic breast cancer. But there is limited data available, real-world data available to know the effect of the treatment on the dynamics of HER2 status. So there were 191 patients selected for the study who are presented with metastatic breast cancer, irrespective of HER2 and HR status expression. So the data collected was in terms of time to next treatment, overall survival and toxicities. The correlative analysis was done for the ERBB2 hemideletions on NGS and liquid biopsy analysis on circulating tumor DNAs. So as I said before, 191 patients were selected. Out of that, 66% of patients were HER2 positive, whereas 23% and 11% patients were HER2 low and HER2 negative respectively. And almost all the patients had received at least 2 lines of chemotherapy before. So the results showed that median time to next treatment was comparatively lesser in patients who have HER2 low and HER2 negative expressions. Also, the patient who had HER2 stable status throughout the process had better time to next treatment compared to those who had HER2 negative at the primary setting, which become low at metastatic, and also those who were HER2 low in the beginning and become HER2 zero at the metastatic setting. So 58 patients were tested for NGS, but data is available for that, HER2 deletions. They found that those who presented with HER2 deletion has a lesser time to next treatment survival benefit. Also 51 patients underwent liquid biopsy. Those who have tumor fraction of more than 1%, there also it was correlated with our study outcome, that is those who are having HER2 low or negative status had lesser TTNT. In terms of toxicities, those patients who had received TDXD, the most common toxicity was associated with interstitial lung disease, and there was fall in left ventricular ejection fractions. 61 patients has to reduce the dose for toxicity, whereas 28 patients has to reduce the dose. So to conclude, TDXD showed the longest TTNT in patients with HER2 positive state disease and those who have the stable HER2 low disease between the primary tumors and metastatic setting. A novel ctDNA test was able to predict the real world activity of TDXD. The rate of interstitial lung disease was 11.5% and cardiotoxicity was 2.6%, which are comparable to those who are observed in the clinical trial, and there were no fatal cases. However, this study showed that time to next treatment was relatively short in this setting compared to those who were in clinical trials. So there is an additional need of research to know the mechanism of resistance and to decide the post-treatment regimens. Thank you.
Thank you, Dr. Nitin Bias. For the next presentation, I call upon Dr. Kunal Jobanputra, who is a consultant medical oncologist from MOC Mahim.
Very good afternoon. So, I'll be presenting the results of use of trastuzumab deruxtecan in very poor subset of patients having HER2 positivity or HER2 low status. So, this is a DEBRA study which basically studied the use of TDXD in patients having active brain metastasis and leptomeningeal disease. So, this was a multi-cohort study done at multiple centers in the phase 2 design. And as we can see, the study had multiple cohorts, cohort 1 to cohort 5. The first two cohorts studied patients having active as well as inactive brain metastasis following progression on local treatment, and the cohort 5 had patients having leptomeningeal disease. And as we can see, the use of trastuzumab deruxtecan was used at 5.4 milligram per kg every 3 weekly. And specifically discussing the cohort 5, here the primary endpoint was overall survival. And if we see the study population, it had very small number of patients, only 7. And the measurable systemic disease at baseline was present in one patient only intracranially at the baseline, and HER2 status was positive in 3 patients and HER2 low was in 4 patients. The hormonal status, ER/PR positivity was in 5 patients and hormone negative in 2 patients. The median number of previous lines of treatment in these 7 patients was 4, and previous systemic therapy, anti-HER2 therapy was received in 3 patients, while endocrine therapy in 3 patients and chemotherapy in all of these patients. So, the overall survival, the primary endpoint in these patients having leptomeningeal disease in HER2 positive or HER2 low patients, the median OS was 13.3 months, and the 16-week OS was 89% and 24-week OS was around 70%. The PFS, according to the RANO criteria which we use for CNS diseases, the median PFS was 8.9 months, and the 16-week PFS again was closing up to 90%, and 24-week PFS around 6-month PFS around 70%. So, promising data. If we see the individual responses, there was no intracranial progression seen in any of these 5 patients in the receiving the TDXD, and most of the patients having clinical benefit rate of around 80%. 1 or 2 patients could not be assessed by the scan, and objective response rate was 20%. However, only I think no patients had intracranial progression and only 2 patients had extracranial progression. So again, this is the summary of the individual patient. What was the status? One of the patient had stable disease at 24 weeks. Other patient had partial response. 1 patient had clinical response, and 2 patients were not evaluable. The side effects were inconsistent with what we see in TDXD, nausea, fatigue, and thrombocytopenia. So to conclude, this was a very small subset of patients, only 7 patients in a very high risk of progression, leptomeningeal disease, that is an unmet need. And as we all know that tucatinib has shown a promising activity in active brain metastasis. However, TDXD, there is a trial which is trying to show some light on use of TDXD in active brain metastasis. And as we know, the cohort 2 and cohort 3 already showed a objective response rate of 46 to 50% of use of TDXD in active brain metastasis. So this, even in leptomeningeal, it is, we can see that there was no intracranial progression in any of these 5 patients, and 2 patients remained on TDXD at the time of follow-up, which was around 12 months, 1 in HER2 positive and 1 in HER2 low. So this remains to be explored further in larger sample size. Thank you.
Thank you, Dr. Kunal Jobanputra. I now call upon Dr. Samiksha Dubey, who is a senior consultant medical oncologist from Wockhardt Hospital, Nagpur.
Good afternoon, everyone. I wish to thank the organizers, first of all, for giving this opportunity. So, So I'm presenting a paper which was presented from our Dana-Farber Cancer Institute in this year's SABCS by Dr. Elisa. It was labeled or titled as Analysis of HER2 Expression Changes from Breast Primary to Brain Metastasis, including HER2 Low. it's changing on its own.
Adjust the animation, please.
So the title of this paper was Analysis of HER2 Expression Changes from Breast Primary to Brain Metastasis, including HER2 Low and the Impact on Overall Survival. We all know from the previous studies that the receptor subtyping, switching, is quite common, and it's very dynamic between the primary and the brain metastasis, and there's a high discordance as far as the HER2 positivity and negativity is concerned. Also, that HER2 low has emerged as a biomarker for the highly active antibody drug conjugate responses, including TDXT, which has shown to have CNS activity in it. So in this paper, the authors investigated the differences in the HER2 expression, including HER2 low, in the matched breast cancer primary tumor and the resected brain metastasis, and they evaluated the impact of HER2 low expression on overall survival. So this was from a single center, Dana-Farber, in which they identified metastatic breast cancer patients with the diagnosis of brain mets between 2003 and 2023. In this group, around 265 patients with resected brain mets had the availability of the receptor status with them, out of which 197 patients had both the matched primary and the brain mets tissue available for the analysis. The overall survival was also determined, and it was calculated from the rate of brain mets resection to the death or the last follow-up. When we look at the results, the baseline demographics and clinical characteristics, 57 patients had the brain-only metastasis, 139 patients had brain and extracranial disease both present at the time of diagnosis. The patients received their CNS diagnosis within 1 year of their initial metastatic diagnosis were 121. Between 1 to 2 years were 21, and more than 2 years were around 55 patients. Out of the 265 resected brain mets, 72% or about 3/4 had some form of HER2 expression, either low or HER2 positivity. Half of them were HER2 positive and about 24% were HER2 low. Out of this, when we look at the properly matched cohort of 197 patients, the primary had HER2 positivity, out of which 97% maintained their HER2 positive status in the metastatic brain met as well. Only 2.6% had a switching from positivity to a HER2 low status. When we look at HER2 low primary identified, more than half of the patients had a switching. 21% shifted to HER2 positive and about 31% shifted to HER2 negative status. The most interesting part was the HER2 negative patients, in which about 40% actually had a switching to HER2 positive, either low or proper HER2 positive status in these patients. Patients with HER2 positive brain mets had a statistically significant lower risk of death at the time of follow-up versus HER2 low. From this curve, we can see the survival of the patients with HER2 positive brain mets for almost 4 years. But when we look at a HER2 low or HER2 negative, it was between 12 to 16 months. The risk of death between the patients with HER2 low and HER2 negative brain mets was similar after adjusting for ER and the age. And patients with HER2 positive brain mets had a better prognosis. In conclusion, over 40% of the HER2 negative primary breast cancer gain HER2 expression in the brain, and nearly 3/4 of the breast cancer brain mets are HER2 expressing, either positive or low. Patients with HER2 low and HER2 negative brain mets have inferior survival, and they are a sort of clinically unmet need, given that they have a therapeutic implication now that we have HER2 targeting ADCs showing an activity in HER2 low patients as well. The limitation of this trial was the use of IHC scoring, which they did for identifying the receptor status, which is known to have intra-observer variation, and they recommend a better HER2 testing sensitive method for the future for this. Thank you.
Thank you, Dr. Samiksha Dubey. And the last speaker of this session is Dr. Smith Sheth, who is a consultant medical oncologist from Thane and Mulund.
Good afternoon, everyone. Thank you, organizers, for the opportunity. So I'm going to be presenting on the aviator trial. Once the Thank you. So this was an aviator trial, was a randomized phase 2 study, which it had 3 arms initially, but then it compared addition of evolumab to vinorelbine plus trastuzumab, and the third arm was addition of utolimumab and avelumab to vinorelbine and trastuzumab. So what is the rationale of adding immune checkpoint inhibitors to anti-HER2 therapy? So we know that trastuzumab acts via 2 mechanisms. One is the antibody-dependent cytotoxic, cell-mediated cytotoxicity, as well as expression of CD8 cells. So we can use this mechanism when we can combine both the drug. So what was utolimumab was a 4-1BB agonist. So 4-1BB is a protein which leads to activation of CD8 T cells. So that was the rationale behind it using. Yeah. So initially it started as a 3-arm study, and it was 1:2:2 randomization. Advanced HER2 positive breast cancer patient, but the patient had to have received at least prior trastuzumab as well as a pertuzumab in the study. PD-L1 was also this. The primary endpoint was to determine whether addition of evolumab to vinorelbine and trastuzumab improves the PFS or not. And the secondary endpoint was to see whether addition of utolimumab increases the PFS. But unfortunately, in 2021, the drug development of utolimumab was stopped, and then the trial was modified into 2 arms. So, yeah. So it's being a phase 2 study, it had only 60 patients, and those were randomized, and they were stratified based on ER status as well as the presence of liver mets. So going to the overall characteristics, the point to highlight is in both the subsets of patients, at least 2 to 3 lines of prior therapy they had received. So treated patients had both received trastuzumab as well as pertuzumab. So this was the PFS curve. So addition of evolumab improved the median PFS from 2 months versus 3.8 months with a hazard ratio which was significant. So nearly doubling of the PFS, considering that these patients were at least in the 3rd or 4th line of treatment. So the overall response rate improved from 11% to 20%. And if we look at the median duration of response, addition of evolumab, it was around 15 to 16 months. It was not evaluable in addition of vinorelbine and trastuzumab arm. So the subgroup analysis, they tried to do whether there are certain biomarkers as we have seen in the previous sessions. So they found that TILs more than 10, patients behaved in a much better way, had a better progression-free survival compared to TILs less than 10%. But this was not seen in the PD-L1 arm. So PD-L1 was not a prognostic tool in this trial. So looking at the side effect profile, nearly 60% side effects in both the arms. There were no untoward or new side effects combining immune checkpoint inhibitor and targeted therapy. So finally, the conclusion, there was significant improvement in PFS with addition of evolumab to chemotherapy and trastuzumab in heavily pretreated HER2 positive patients. The utolimumab, the drug 4-1B, did not improve PFS. And high TIL can be used as a surrogate markers, but yes, requires more detailed phase 3 randomized studies. There was no association with high PD-L1 or low PD-L1 expression with improvement in PFS. No unexpected toxicities, and further, we need more data with randomized trials to, in this pre-treated HER2 positive patients, combining targeted therapy and immune checkpoint inhibitors. Thank you.
Thank you very much, Dr. Smith-Sheth. We now have the last panel discussion of the day and of the conference. And as moderator, I would like to call upon Dr. Chetan Deshmukh, who is a consultant medical oncologist from Dinanath Mangeshkar Hospital, Pune. Excuse me. I'll quickly call the panelists. Dr. Kshitij Joshi, who is a consultant medical oncologist from Vilepale. Dr. Pankaj Goyal is a consultant medical oncologist from RGCI. Dr. Krupa Shankar is director and consultant medical oncologist from NSR CanCure Center, Coimbatore. Dr. Rajat Bajaj, director medical oncology, IOSPL Fortis Hospital, Noida. Dr. Devendra Pal, consultant medical oncologist from MOC Panvel. Dr. Sharda Mylan Kodi, who is an associate professor, Department of Medical Oncology, Kasturba Medical College, Manipal. Dr. B.K. Smriti, senior consultant medical oncologist at Leelavati Hospital, Mumbai, and Dr. Vivek Agrawal, also to come and join the panel.
Thank you, MOC, for inviting me here. I'm aware that I'm the last moderator, so I'll try to be as brief as possible. I know I'm standing between you and a well-deserved lunch. The topic for discussion is advanced breast cancer, and as I understand, all our panelists are medical oncologists. Am I right? So the discussion is going to be focused only on systemic therapy. Excellent. So, I was told that this will be a case-based panel discussion, but most of these abstracts and the drugs are not as yet available. One drug was launched just few days ago. The other drug is yet to be available, and the another abstract which was shared to me is actually a phase 2 study. So it's a little too early to debate and discuss about cases, but to start with, we have a 58-year-old lady who was diagnosed with breast cancer in October 2021. Breast conserving surgery was done. The histopath was invasive duct carcinoma grade 3, PT1 and TN2. She had 5 out of 17 nodes which were positive, and ERPR was negative. HER2 neu is 3+. This is a true patient. This lady actually is receiving treatment with me right now. She received adjuvant chemotherapy, docetaxel, carboplatin, trastuzumab, followed by trastuzumab maintenance till December 2022. She presented with headache and vomiting, diplopia in October 2023. The MRI brain revealed a solitary lesion in temporal lobe with surrounding edema. PET CT, no evidence of extracranial disease. So I wanted to ask you, maybe we can begin with Kshitij. What proportion of your metastatic breast cancer patients present with de novo brain mets?
So we are talking about in general or only HER2 positive?
The next question is in HER2 positive.
Okay. So
in general?
In general, 20% or something in HER2
De novo, in HER2 positive, 20%. Okay. Anybody has a smaller or higher proportion?
Upfront metastatic, I think we find around 10% or so.
Yeah.
In the course of their journey, they will have metastasis later on, and HER2 positive, I think 1/3 will have metastasis at certain time.
Yeah, that is true. The incidence in upfront metastasis is much less, but as the disease progresses is 10 to 30%. Yes, in fact, at autopsy they have found as high as 30%. Young age, HER2 positive or triple negative disease and extensive extracranial disease is definitely at a higher risk of developing brain metastasis. They generally carry a worse prognosis, but HER2 neu positive subset has shown to have the most benefit with whatever treatment you offer them. So for this lady, she has only a solitary CNS metastasis. So what do you plan? Of course, local therapy has been offered. Is there any other thought about local therapy, local radiation or surgery? What do you do? It's a solitary met. Let's say for discussion's sake, it's about 1.5 centimeters. The edema has gone with medical treatment.
If it is a solitary metastasis and the patient is having a good performance status and less than 3 centimeters, there is data to suggest that surgery and SRS, both of them have got equal benefit. But having said that, now when I was reading these abstracts which have now come up, so they have actually revealed something which is very important for us as clinicians, that there can be a change in the HER2 expression as well.
Yeah, just a minute. So let us say that she did undergo surgery, the tumor was removed, and it is now triple negative. Does that change your systemic therapy?
As of now, no. So
then why do it?
Yeah, so that's what I'm saying, that suppose it's from positive to negative, doesn't really make much of a change, but if it is negative or a HER2 low going to a HER2 positive, we do understand
let's not take HER2 low right now. We'll come to that. HER2 low, we'll come to that. But yeah, that was an interesting abstract, that there is some discrepancy as the metastatic disease goes from one place to the other, there is likely to be some change in the biomarker. In fact, there's a Japanese study, I didn't put it here for lack of time, but there's a big study, even with neoadjuvant chemotherapy, your biomarker status change. It's a almost 20,000 odd cases study.
Yeah.
So for such patient, now this lady has undergone local therapy. She did not undergo surgery. This lady underwent only local radiation therapy. Forget about the specifics. She doesn't have any extracranial disease. So would you like, Dr. Devendra, would you like to offer her any systemic therapy?
If there is no extracranial disease, then systemic therapy maybe hold on, because like brain is basically a sanctuary site. So extracranial disease is controlled, and maybe some cells which are stayed in the brain, and chemotherapy didn't reach, so they have multiplied. So
but they always say that breast cancer is a systemic disease and a local relapse is just a harbinger of systemic relapse. So what do we do?
You can just hold on systemic therapy.
Okay.
Local therapy is good enough.
Okay. Anybody else has other thoughts? Dr. Sharda or Dr. Vivek?
So I would offer systemic therapy with some sort of a
So
pseudo,
what systemic therapy?
pseudoadjuvant
This
intent.
lady completed her adjuvant trastuzumab in the month of December 2022, relapsed in October 2023.
Yeah.
Trastu-free survival less than a year.
Yeah, so I would be happy offering some sort of
No, what therapy?
taxane, in this situation, after if it's a solitary meds and it has been irradiated, so later I would be happy to offer TCHP.
She's already completed TCHP. Her original adjuvant therapy was TCHP.
Correct.
TCH,
I would
not
want to restart her on either a taxane platinum combination with pertuzumab and trastuzumab, because for me this is a metastatic disease.
Okay.
And I would want to treat it like a metastatic disease.
Okay, so I'm just, if I get it right, this is a metastatic disease. We are looking at a palliative situation, and you still want to give a combination chemotherapy, not a single agent chemotherapy, along with HER2 targeted therapy.
Yeah, it is because it's brain metastasis, and I think platinum will have some intracranial, more.
Why not
and
single
taxanes
agent
will
platinum?
not. No, we have to combine it with a anti-HER2 agent, and I would be happy to offer him, some chemotherapy with anti-HER2 therapy. And if I have to select an anti-HER2 therapy, I would select trastuzumab plus pertuzumab. And if I have to select a systemic therapy to start with for initial few cycles, I would prefer to give a taxane and a platinum combination in this setting,
Okay.
because of the brain metastasis. If it had been outside the brain, then I would be happy.
We are coming to that. Anybody else in the panel would like to have a different
If at all, I will offer to this patient who has recurred in just 1 year, rather than re-challenging the first line therapy, I will probably offer either, most probably TDM1.
TDM1 as a single agent?
That has got intracranial activity which is supposedly better than LabCap in one of the retrospective study. So you
Okay.
have to discuss with the patient how comfortable is the patient with the injectable, or the patient wait and watch is also a valid option.
Okay, the patient is okay with either. So TDM1 is your choice. Yes, doctor. Yeah, go ahead, Dr. Shan.
I would also prefer to give some systemic therapy in this case because it's a brain metastasis. And I think I agree with sir in that I would also choose TDM1 because it has a chemo plus HER2 target together in that this thing. If the patient cannot afford that, probably lapatinib and capecitabine is a kinder option since it's an all oral this thing and logistic issues. The only problem is how long to continue. Is it like a adjuvant setting or metastatic setting where we have to continue it indefinitely? It's always a problem in this metastatic RCC where everything has been excised, and this kind of case where all the metastatic sites have been taken care of. How long we will continue the
Of course, that
pseudo-adjuvant therapy.
that is always going to be a problem with limited metastatic disease. You had something to say.
So I will certainly like to offer, I will not like to leave the patient just like that. I saw that it was a PN2 and the patient has relapsed within 6 to 12 months is the bracket that we see. Now talking about the therapy which
The question here is, what anti-HER2 therapy you are going
Yes.
to decide.
So-
You are going to combine it with chemotherapy, not combining, that is a different matter. So the choice, right now we have a choice of Trastu, Pertuzumab, Lapatinib, TDM1, and now 4 days ago they've launched TDXT. So we have a choice of these 4. Which one are you going to take? Sir said it's TDM1. She said LabCape or TDM1. Vivek wants to use Trastu Pertu.
Yeah, I mean,
you know, in the initial TDM1 trial, clearly I would go by that. Less than 6 months of relapse, TDM1, more than 6 months of relapse, then you can, you know, of course, go again back
I
to
get your point.
TCHD.
Yeah, fair enough. You want to re-challenge. Fair enough.
So 6
Your
to 12
choices.
months is a gray area. Less than 6 months is Amelia study, and even in Destiny Breast 03 included less than 6 months. Cleopatra is more than 12 months. Indian guidelines, just I think 2 years back, suggested that 6 to 12 months you should treat like less than 6 months way.
Right. So you
And
would not
for
like to
me-
re-challenge with?
For me, yeah, not re-challenge. If I can lay my hands on NHER2, patient can afford, it's definitely. If not, then TDM1.
So if there is extracranial disease, does that change your plan?
No.
No,
As of
your
now,
plan
no.
remains the same.
Remains
So
the
there
same.
is limited volume of extracranial disease. Say she has a couple of lung nodules, a small liver met. Will that change your plan or it's going to remain the same?
It's going to remain the same.
Fair enough. Any personal experience with TDXT or tucatinib, any one of you as a part of clinical trial or compassionate access? Yes.
I have an experience of tucatinib and it's except diarrhea as a side effect, otherwise tolerated well. But we need a dose reduction, and it has a very good result that I have got only in that patient was a control of disease, multiple treated for almost 9-10 months, very good control.
Fine, fine. So the reason why I brought this up was the HER2CLIMB-02 study, tucatinib and TDM1. Just to refresh your memory, this is the original HER2CLIMB study, tucatinib, trastuzumab and capecitabine for HER2 positive metastatic breast cancer, where they showed improvement in the progression-free survival. This was published, I think, 3 years ago. There was some improvement in the PFS. This study, HER2CLIMB-02 study, had 460 patients randomized to TDM1 plus tucatinib versus TDM1 plus placebo, and the usual PFS and OS were the endpoints. In this group, this patient, again, fairly heavily pretreated patients. In this group, amongst all comers, the PFS benefit numerically is about 2 months, and so is true with the patients with brain metastasis. But this subset typically does poorly with all other therapies. So for this subgroup, I think if you have a PFS benefit of over 2 months, I think that is fair. What do you think? So tomorrow morning, say tucatinib is available. Tomorrow morning, a lady with brain metastasis, HER2 positive walks in. Are you going to offer tucatinib? Let's say it's available.
No.
Why?
No, not this combination.
Tucatinib, we are discussing tucatinib.
So I'll be better off offering a HER2CLIMB protocol rather than a HER2CLIMB-2 protocol as of now.
So you would give Trastu, Cape,
because this is in the second line and that is in the third line.
Fair enough. But you would still think of tucatinib.
Certainly.
So the problem with tucatinib is the treatment emergent adverse events have been multiple. You know, a fair amount of patients have more than 60-65% patients have had more than grade 3 and above treatment emergent side effects. Some of them have been bad enough to produce death. A significant proportion, almost 1/5 of the population, discontinued treatment to tucatinib or placebo due to these side effects. So that can be a problem. All types of side effects are more with this combination of TDM1 with tucatinib compared to TDM1 with placebo. So, and discontinuation is also a big problem. So this is why, you know, we are looking at a patient who is essentially an advanced metastatic disease. You are going to, if your therapy is continued, the treatment is going to help. If the therapy is discontinued, then no matter how good the therapy is on paper, it's probably not going to benefit the patient at all. So tucatinib, well, we'll probably get to know more about it the way we learned with so many other drugs. We'll probably start off with a lower dose or be a little quick with de-escalating the dose, begin with the standard dose and cut down, something like that. We'll learn as we go, I'm sure of that.
So I think we have TDXD available, then probably that will be the preferred second
I'm
line.
sorry?
If we have TDXD available, probably that will be the preferred second line agent. If that is not there, then probably I'll use TDM1 first, and then we have a very good data of HER2CLIMB study. So I'll reserve the tucatinib for the third line.
So breast cancer patients, even with metastatic disease, usually maintain their PS. So PS is 0-1, PS is okay. Many a times
PFS in the tucatinib HER2CLIMB study was much better as compared to what they have demonstrated in second line.
Fine.
And
So
also, if we see this trial, probably the TDM1 only arm has underperformed compared to what was in the Amelia study. It's almost like Amelia study, 2 months difference, 9 versus 7. So probably.
Fine. So leptomeningeal carcinomatosis is a different beast altogether. You know, it's not the usual brain metastasis. The spread is very aggressive, and so what is your experience with, so how do you manage your leptomeningeal carcinomatosis? It's a troublesome situation. Patient comes with headache, vomiting, CSF is positive, MRI shows that there is extensive leptomeningeal disease. How do you go about it? Yes, Dr. Sharda, if we can begin with you.
Sir, right now we are giving triple intrathecal therapy twice.
Triple therapy?
Yes, sir.
So what are the components of triple therapy?
Araci, hydrocortisone and methotrexate.
Araci?
Cytarabine, sorry.
Yeah.
Cytarabine, hydrocortisone and
okay, so the lymphoma protocol is just extrapolated here. Dr. Devendra?
I use single agent methotrexate only intrathecal along with systemic therapy because studies have shown that a single drug is almost as effective. We don't add much, we add multiple drugs.
Yeah.
Yes.
I think, you know, we have a few case reports published about intrathecal trastuzumab.
So do you use it?
And I have used in 2-3 cases with a fair amount of success. So I'm comfortable using intrathecal trastuzumab with you know, systemic therapy, and 2 of the cases I've added intrathecal methotrexate also.
Okay.
While one case we just gave intrathecal trastuzumab.
Yeah, so basically single agent methotrexate plus or minus.
Yeah, I would want to, you know, sort of give.
Fair enough. Yes, you are saying something.
I think similar to what others have said.
Any takers for
IT,
craniospinal radiation?
No.
Any radiation oncologists in the crowd who would like to take it? Any takers for craniospinal radiation?
Our radiation oncologists refuse for that.
Yeah, it's a toxic issue, and most of the patients are, they become miserable with craniospinal artery. So here, you know, there was an abstract which mentioned about HER2 low subset. So what is HER2 low? By definition, what do we mean by HER2 low? So patients who have HER2 neu 1 plus by IHC or HER2 neu 2 plus by IHC but negative by FISH are the ones who are classified as HER2 low, and HER2 neu 3 plus on IHC or 2 plus but positive by FISH are true HER2 positive. So far all our therapy has been directed towards HER2 positive. Every therapy we've been told that you have to have a patient who is HER2 positive. If it's HER2 negative, we were not using any HER2 targeted therapy in such patients. So HER2 low and HER2 ultra low or null were always excluded. But now this has become an actionable, HER2 low has also become an actionable target to HER2 targeted therapy. This was the Destiny 4 study. Metastatic breast cancer patients with HER2 low status categorically, over 500 patients. They were treated with trastuzumab deruxtecan versus physician's choice of treatment. Fairly heavily treated population, more than 60% of the population had received 3 lines of systemic therapy, and a fair amount of them had visceral metastasis, lung, liver mets. Few had also brain metastasis. The curves are quite impressive. You know, for this kind of a population, if you have a doubling of PFS both in the HR positive and amongst all comers, it is really impressive. 10.1 versus 5.4 and 9.9 versus 5.1. Even the overall survival, 23.9 months in a heavily pre-treated patient is really, really impressive. So coming down to the use of TDXT. So TDXT in a heavily pre-treated HER2 low population will also work well. Now this was a study which was just presented patients with HER2 low, HER2 enriched, everybody. But the focus which we are looking at that cohort of leptomeningeal carcinomatosis had only 7 patients. A very small subset of patients. So for this group of patients, would you be happy? Now you have a choice of trastuzumab intrathecal, and now you have a choice of TDXT.
So trastuzumab intrathecal, there have been case reports, retrospective data, phase 2 study just this year. The PFS has been to the tune of 7 to 8 months. Here the PFS is about 9.5 months. This is supposedly a better drug as far as the other data is concerned. So if cost is not an issue available, I'd like to use this.
Yeah. So cost is going to be an issue for quite some time now. So let's hold it to that. But yeah, it has, and of course it's not an easy drug to receive. Any experience with TDXT in any one of you as compassionate use or on a clinical trial?
So we have used it in the clinical trial.
Yeah.
And the lung toxicity, what we found grossly was lesser than what has been reported in our patients. So
Okay.
yet I think we need more experience, but I think it was not that dreadful the way it has been reported.
Right.
Maybe
That's
in the study they have studied the larger number of patients. In your center, there must be few patients.
Yeah, but that's heartening to know that the toxicity is not so much. But yeah,
we have used in neoadjuvant setting in a clinical trial, and the experience has been good. Looks like a, quite a tolerable drug. Has mild hepatotoxicity in terms of raised liver enzymes, nausea, vomiting is an issue, and some anorexia is an issue. And interstitial lung disease, so far, I know we treated 7 patients, we didn't get any interstitial
not a single
lung
one.
disease.
That's good, that's good. But yeah, all said and done, leptomeningeal carcinomatosis is a tough disease to treat, and most of the this thing has been not very rewarding. All the studies have been very disappointing, and this study is too small. Actually, just 7 patients, so it's almost impossible to comment on anything. But let's look at this as okay. This may also work. Coming down to the last study, last part of my discussion, the aviator study. The first time, it's a phase 2 study, first time in a HER2 positive subset, immunotherapy has been used. And not only one immunotherapy drug, but 2 immunotherapy drugs, avelumab plus utomilumab. This patient, this cytotoxic chemotherapy, we know we combine it with immunotherapy sometimes to modulate the tumor microenvironment. This may increase the cytotoxicity of T cells. This has been reported even in metronomic doses with platinum compounds, taxanes and vinca alkaloids, though this data largely comes from lung cancer and head and neck cancer. But well, there is a place for using either platinum compounds, taxanes or vinca alkaloids. And that is why this study, now we thought that we had PDL1 and CTLA4 and TMB all sorted out. Now we have a new target, 41BB. This is a co-stimulatory receptor of the tumor necrosis factor superfamily. It dampens the host's immune response. It preferentially interacts with CD8 more than CD4. And if you have 41BB agonism, then it is found to be synergistic with trastuzumab. This is of course in preclinical studies. That was the logic of combining it in this combination. So this was the aviator study, advanced HER2 positive cancers. These patients were prior treated with trastuzumab, pertuzumab and TDM1, no prior immunotherapy or vinorelbine, and PDL1 unselected, so all comers. Patients were grouped into vinorelbine plus trastu, vinorelbine trastu avelumab, and vinorelbine trastu avelumab plus utomilumab. To cut it short, the green line shows the avelumab arm, and the red line shows only the trastu plus vinorelbine arm. The green line looks better. The PFS is almost doubled at the pre-specified interval. The overall response rate also looks better. So immunotherapy, right now we are not using immunotherapy in any of the HER2 positive, but if at all, do you combine trastuzumab with any of these low-dose chemotherapies, either vinorelbine or taxanes as a routine for a longer?
So I have combined immunotherapy with trastuzumab, but not in breast cancer. I've done that in gastric cancer.
Gastric cancer, okay.
But in breast cancer, I have not done
So
yet.
what was the experience? Gastric cancer, HER2 positive plus you gave some immunotherapy.
Yeah, so it was just 2 patients that I have done, and the response has been good till now. I mean, I don't know how much the immunotherapy has helped, because most of the HER2 positive patients, they tend to have a PDL1 positive.
Because
cancer,
the other place where they have tried this was the gallbladder carcinoma, where they had patients who were HER2 positive and who were also offered durvalumab. The subset with HER2 positive disease did not do so well. So that was why I was wondering how come they have combined it. But well, they seem to have their homework done. But nevertheless, an interesting combination of avelumab plus
If we
utomilumab.
see the difference in the PFS, though it appears it's double, but it's hardly 1.8 months. So
Yeah,
in
yeah.
third line, we have better agents available. I don't think we'll be jumping on that.
So these patients have been treated with all three.
They were, I think, third line and beyond.
Yeah, yeah, third line. So they have been treated with trastuzumab, pertuzumab and TDM1.
So, lap cap and tucatinib is still,
yeah, lap cap.
TDHD,
Oh,
TDHD
yes.
is still there with us. So this
The
is
lap cap, somehow people, I don't know why people don't like lap cap. You know,
So
when we
tucatinib-
were discussing, nobody said lap cap except maybe Dr. Sharda
tucatinib
mentioned
cap
it.
and trastuzumab is still available. TDXD is available.
Yeah, TDXC, well, it has become available, but till the time it becomes accessible to a large majority, I think it's
So
going
for
to be a
1.8 months improvement in POS, I don't think we are jumping on that.
Oh, interesting. Yeah, lap cap is I think the problem is with the combined toxicity. Both lapatinib and capecitabine can cause terrible diarrhea, and that really affects the quality of life. Yes, doctor.
The keynote 811 study that we are just talking about, the gastric study, that also had this 4-1BB receptor being seen in the exploratory analysis, and that was the best subset. There is, for some reason, in the preclinical studies also, Pembro plus trastuzumab has been the best combination with trastuzumab. The GB study did not have a trastuzumab being added to Durva at that time.
No.
But then, yes, this is something interesting, food for thought for us probably.
Definitely.
But there are, as of now, better agents available.
Definitely. So I think we are end of our, so last slide.
Just a question.
Yes.
So what are your thoughts on that TIL? Because they have some subset that TIL, they have a better response. What is?
Yeah, higher baseline TIL. Yeah, but then, well, TIL,
Too early to.
it's too early to say. Yeah. So apparently the
TILs we all know is a prognostic, you know, and as I explained in my talk that now there are diagnostic assays which take into account the TILs also in, you know, determining a score as to how anti-HER2 sensitive the patient will be based on all those factors. But you know, it does make a difference, but right now in our clinical practice we are not including it. But you know, maybe some years later.
Yeah, maybe our pathologists also need to train themselves into identifying the TILs, the areas, the standardization of measurement of TIL. There is still a long way to go before we can include it in our day-to-day practice. So thank you panelists. Thank you very much for that interactive
I
session.
thank all
you.
the panelists. May I request you to please be here. Dr. Mekha, will you like to conclude something of the session? And then I'll request all the speakers also to please come up on stage for the picture. Speakers, Dr. Lavin, Dr. Nitin, Dr. Ankit, Dr. Samiksha and Dr. Smith.
I think we had an excellent panel discussion here. We had an esteemed moderator and very well-known panelist. And thanks to all panelists and the presenters for excellent session.
Thank you very much, Dr. Mangesh Mekha. We'll have the picture now. Thank you very much. And it's my pleasure to invite Dr. Chirag Desai to present the conference summary since we have come to the end of this conference.
So good afternoon, everyone. The conference has come to the end, and in next about 15 minutes or so, I will be discussing the summary of the abstract that we discussed in last 2 days. And before I begin, let me tell you that everything that was discussed was excellent. I don't have any idea to undermine what is not being presented by me in next 15 minutes. Everything was excellent. I have picked up what I found easily and important. So it will be like a rapid fire slide show. I will show several slides in next about 15 minutes. So early breast cancer, and this presentation was done by Anne Partridge from Dana-Farber. So axillary lymph node dissection. So this was a trial, Sinomec trial, to dissect or not after positive sentinel lymph node biopsy. And there have been several trials which shows variable results. So this trial was conducted for T1 to T3 primary invasive breast cancer, clinical node negative, mandatory preoperative axillary ultrasound was done, and breast conservative therapy or mastectomy, and up to 2 sentinel lymph nodes macrometastasis patients were selected, and patients with medical contraindication for radiation or systemic therapy were excluded. So 2000 plus patients, 920 mastectomy, the other breast conservative therapy. The standard of care, completion of ALND was done in 1060 patients, and no ALND, despite positive sentinel lymph node, was done in 89.4 patients, and practically every patient received some sort of systemic therapy. So what we can see is there is non-inferiority. At the end of 5 years, there were 191 RFS events, and 8% in ALND, 7.1% in no ALND. So it means that if we are radiating chest wall or breast with axilla, we don't have to go for ALND, and we can avoid the toxicity of ALND in some patients. And some of the surgeons may counter the argument that if we avoid radiation to axilla, then also it's a good way. But this is the trial that was presented, and that was a good trial with good number of patients. Something about regional nodal radiation. So in the patient who were pathological N1 to begin with, and after neoadjuvant chemotherapy, if they were converted to N0, the patients were randomized to undergo no radiation to axilla versus regional nodal radiation. So look at the bottom left-sided table. It shows there's no regional radiation with breast XRT BCS and no chest wall radiation if there was mastectomy. So there were good number of patients. We had a discussion on this point yesterday. That if the patient was having T3 and becomes a N0 after neoadjuvant chemotherapy, whether to spare radiation to these patients or not. So we don't have any clear answer to that, but this is the larger population, 1,500 patients. No RNI in 784 patients and regional nodal radiation in 772 patients, and almost 5 years of follow-up of this patient. And we can see that the graphs are overlapping for ipsilateral breast cancer recurrence-free survival as well as distant recurrence-free survival. So if the patient becomes N0 after neoadjuvant chemotherapy, if mastectomy, don't give any radiation. If breast conservation surgery, give radiation to breast and no radiation to axilla. So ICI, we are giving in triple negative.
Interrupt. May I request all the people who are at the back of the hall to please carry your conversations outside the hall. You are too loud to be heard right here in the front. May I request you all to please go out of the hall and carry out your conversations. Thank you very much.
Thank you. So immune checkpoint inhibitors we are using in triple negative breast cancer, but there are a couple of abstracts which were presented in hormone receptor positive breast cancer. The first was Keynote 756 study, paclitaxel with pembrolizumab for initial 3 months, followed by AC and pembrolizumab for subsequent 3 months, followed by surgery and followed by maintenance with either pembro or placebo. And the other trial was nivolumab trial, Checkmate 7FL study, the nearly similar design, Pacli and nivolumab versus Pacli and placebo, 3 months followed by AC, either 3 weekly or 2 weekly, 4 cycles with nivolumab or placebo. So pathological complete response was higher in immunotherapy arm, but here in hormone receptor positive subset, I am wondering whether it is really essential to look at the pathological complete response or not, whether there should be the endpoint or not. In this trial, there were 2 endpoints, 2 co-primary endpoints. One was pathological complete response, the other was event-free survival. So we have achieved first endpoint, that is PCR, and this is how it looks. There is a difference of 8.5% in Keynote study and 10.5% in Checkmate study. I don't know how to interpret this study, and Senthil had conducted very good panel discussion yesterday on this point, and he had shown that low ER positivity, high PDL1 positivity are having a very different PCR rate, and that could be the subset where we can look at this particular sort of treatment. But picture abhi baki hai. We need to look at the event-free as well as overall survival for a longer time. So we await desperately EFS data, and now we have some biomarkers need to determine the best biomarker or combination of the biomarker to predict PCR and EFS. And we should keep in mind that the toxicity of immunotherapy is not trivial. It exists. We should not turn the blind eye on those toxicity. So two landmark trial that we have been discussing quite frequently in last year or so, Natalie trial and Monarch East trial. We have the 3-year update of Natalie trial and 4-year update of Monarch E trial. Different subsets of the patient. In Natalie trial, relatively earlier patients have been selected, N0 and biologically high risk like grade 3 or high Ki67. And at the end of 3 years, there is 3.1% difference in the invasive disease-free survival. Little early, we want to look at little further data, but when to accept this data in our practice, that's always a dilemma. When the ATTACK trial was being presented with 3 years and 5 years and 10 years follow-up, some of the people started accepting the ATTACK data at 3 years, and some of the people were not accepting even after 10 years. So we have to have some deadline, and to me it is 5 years when I will accept the data. At 3 years it looks better to add ribociclib. The dose of ribociclib also is a controversy. In this trial it was 400 milligram to be given for 3 years, and we don't want to touch on the controversy. This is how it looked in this presentation. And Monarch E, really clearly high risk patient in cohort 1, 91% of this patient, and little controversial cohort 2 where the high risk was determined based on the Ki67. But in this data, at the end of 4 years, the difference is striking. There is 6% difference in the outcome at the end of 4 years. So both ribo and epima improved the EFS in the high risk, and US FDA has accepted, it has approved abemaciclib as adjuvant therapy, and ribociclib is yet to approve from US FDA. What we have realized in the biomarker analysis is that MYC amplification is associated with resistance to abemaciclib. So if we find MYC amplification, we may avoid abemaciclib in this patient. ICN triple negative breast cancer, the further analysis, and this is exciting, Keynote 522 study that we have been discussing for 3-4 years now. At the end of 7 years, we have very good data, and the difference in the event-free survival is the absolute difference of 9%. The difference is more striking in the patient who did not achieve PCR, less so in the patient who achieved PCR. But if this is the data, it becomes the reason to incorporate pembrolizumab in every patient, at least those who are affording for pembrolizumab. Adjuvant immune checkpoint inhibitor, if for any reason if we miss to give neoadjuvant immune checkpoint inhibitor, Adaxantra or IM patient 030 is the study where atezolizumab was given as adjuvant therapy, and it failed. It has met the futility endpoint. The trial has been discontinued. So if we want to give, we don't want to enter in the controversy of atezo versus pembrolizumab, but if you want to give immunotherapy in TNBC, give it as the neoadjuvant therapy, or in metastatic, don't give as adjuvant. So Catherine study update. Again, we know the Catherine study, but now we have excellent update. At the end of 8.4 years, there is excellent separation in the curves, 11.7% difference in the two arms. So this is also something that we need to accept in practice without any further discussion. Site of first metastasis everywhere, TDM1 is better than trastuzumab, except for CNS. There is slightly increased incidence of CNS event from 5.1 to 7% CNS event. Maybe because of longer disease-free survival, it may be the reason, but this is something that we need to look at. Median overall survival also different by 4.7%, at the end of 7 years. So that also is exciting. For increase of 2 to 3%, we have been giving chemotherapy and doxorubicin and taxane, and this is the old story. So addition of 4.7% at 7 years is significant for HER2 positive patients. Switching to metastatic breast cancer. So this presentation was made by Professor McGregor of MD Anderson Cancer Center. We have 4 different approaches of continuing CDK4/6 inhibitors beyond progression: maintain trial, PACE trial, Palmyra, and post-Mozart trial. We don't have the data of post-Mozart trial, but for the other two, look at the bottom line. PFS is 5.3 months, 4.6 months, and 4.9 months. Very small difference. So if we look at the current trials of ADC and few other drugs, I think I am not encouraged to use CDK4/6 inhibitor in maintaining the response of this patient, or rather on progression by switching the endocrine therapy. So I don't recommend that looking at this data. INAVO 120 study, it is something like alpelisib study. But in alpelisib, it was alpelisib fulvestrant versus fulvestrant alone. While here, a similar set of patients, PIK3CA mutated patient, hormone receptor positive, inavolisib, palbociclib and fulvestrant versus palbociclib and fulvestrant as the second line therapy. Of course, there were some toxicities which I have not mentioned in my presentation, but we look at the excellent separation of the curves of PFS at the end of 2 years, and the PFS is 15 versus 7.3. So excellent hazard ratio, excellent p-value, hazard ratio of 0.43. CAPITAL-O is another good study where irrespective of biomarker, we are giving capivasertib with fulvestrant versus placebo and fulvestrant as subsequent line of therapy to metastatic hormone receptor positive breast cancer. So we see the alteration, improvement in the PFS in both the arms, irrespective of biomarker and with biomarker. And when we talk of biomarker here, it was PIK3CA, AKT, and P10 alteration. All 3 biomarkers are put together. The drug has been approved for biomarker positive patients, but we see the improvement in the biomarker negative patients as well. So that is something to be pondered about. And finally, HER2 CLIMB-2 study. In Chetan's discussion in the last panel discussion, I was thinking that we need to, it is high time that we need to have HER2 CLIMB-3 study where we combine TDXD with tucatinib. But let us see if someone does that. That will give a good CNS outcome, hopefully. But HER2 CLIMB-2 study randomized the patient between TDM1 and tucatinib versus TDM1 plus placebo. And there were toxicities, as Chetan rightly discussed. In patients with and without brain metastasis, the PFS was 9.5 versus 7.4 months and 7.8 versus 5.7 months. I think this is my last slide. We had the excellent discussion. This was just a bird's eye view of what we had discussed in last 2 days. Everything was important, but this was my take from last 2 days discussion. And I apologize if I missed some significant development in last 2 days of discussion. Thank you very much.
Thank you very much, Dr. Chirag Desai, for summing it up so well. And we come to the end of this academic feast. I'm sure you have a lot of take-home messages in your kitty, and it has helped to empower you with the latest updates in breast cancer management. I invite you all for lunch now before we take leave. Have a safe journey back home. Goodbye and have a good day. Thank you.